appear for the exam and you will be waiting for the result. So with this, I will, and this course was very well designed and meticulously arranged by our convener, Dr. Aarti Shahade Madam, and our dynamic president, Dr. Meenakshi Deshpande, and the coordinator for this program is Dr. Gitanjali Sharma. So this introduction, I will let you know the few announcements for future programs of IMA Pune. So on 21st, just 2 days after this, we are having yoga day session. It will be from 7 a.m. to 8 a.m. with the yoga therapy expert, Dr. Nivedita Pingre, and it will be in the Kelkar Hall, and it is along with the Pune Obstetric and Gynecological Society and Menopause Society Pune. Next thing is that on 22nd we are having a webinar on diabetes and cardiorenal complications. It will be from 6 to 9 in the evening. So you can join that. It is not having any MMC points, but for your knowledge, I think it will be better if you join that. Then again on 23rd, we are having the medical health checkup camp for Varkaris. It will be in the same premises. And on 24th, from at 5 o'clock in the morning, we'll be proceeding to Pandharpur till Saswat will be going. Our IMA team, IMA Pune team will be going. So you can join in large numbers. We are having again on 1st July, we are having a blood donation camp at Waknewadi. It is in the Abbott office. It is from the Abbott laboratories will be organizing it. And in the afternoon, we are having a CME from 3 p.m. to 6 p.m. Then it is with the MMC point. It will be on the stroke management. And on again on 10th July, we are having a CME with in association with Janakalyan Blood Bank. Sorry. So with this introduction, I will call upon and I request Dr. Meenakshi Deshpande, our dynamic president, to come on the dais to give her opening remarks.
Yeah. Good morning, everybody. At the outset, when we start this concluding session of the diabetic course, as you can see, the name of the diabetes course is IMA Pune Online Certificate Course on Evidence-Based Diabetic Management. So this is the last module consisting of a diabetic food workshop and a concluding session of this course. And this is it was a welcome concept which we had conceived in the month of November last year of having a diabetes course online for many delegates of IMA Pune. Plus, because it was an online, it could go to even beyond Pune. And I'm very much glad to say that because of the efforts of Dr. Gitanjali Sharma, Dr. Aarti Shahade Madam, who conceived this course and very meticulously planned it, we could have a lot many delegates than what we actually were expecting that time. So we were expecting to the tune of 50 to 60, but we have got nearly 180 registered delegates for this course from all over Pune, Maharashtra, and even from India. That is, we have gone beyond Maharashtra also for this course. And I'm very glad about this, that we could reach this number for this course. That was my first point. Second point is that, you know, diabetes is now increasing. Diabetes is coming on even in a younger population, not only for our non-medicos, but it is seen nowadays in the medicos also. And our theme, that protect your healers, this theme applies to yourselves, because I would request from this platform, all your colleagues and friends, please check yourself for diabetes. Please check yourself for diabetes frequently, every year or every 6 months, because that is the time when we diagnose diabetes for no reason. Patients come, but doctors don't come. Doctors are not there who manage their complications of other patients, their relatives. But can I ask the doctors how many of yourselves are doing your routine health checkup every yearly? So that was one point which I have to make and I must make at this August gathering today, because I am reaching not over to Pune, I am reaching outside Pune to Maharashtra, outside Maharashtra, in all over India just now. So I would request all the doctor fraternity, the medico fraternity, right from young age, to please keep on doing their health checkup and also go on doing their, not only their staff, their relatives, but their own also. The third point which I wanted to have is a blood donation camp which we are having on 10th July, that is Sunday morning. So I expect all of you who are staying active, staying fit, to donate their blood for a very just cause. Come up to IMA Kelkar Hall on Sunday 10th July at 9 a.m. So we are having this blood donation camp on Sunday morning, and I would request you to donate blood in large numbers. The last and the most important message is about our UConn. UConn we are holding is a Maharashtra State Women's Doctors Wing Conference. It is a 2-day conference, 27th and 28th August. It is at Royal Connaught Boat Club. It's a very nice venue with a very good ambience. And I know all the ladies doctors would of course enjoy it along with the gents doctors. So I would request all of you to register fast, because we have planned an excellent program, not only an academic program, but also a cultural extravaganza in the evening. And that is the hallmark of UConn. UConn is not only for the ladies doctors, also for the gents doctors, because we are having 4 MMC points along with excellent scientific sessions regarding women's health. The theme is women's holistic well-being. So we are having all the sessions related to women's health, and of course, even the gents doctors can participate in the cultural extravaganza. They can also participate through the team IMA events which we are planning in the on the Saturday evening from 3 to 9 p.m. So the scientific program is from 9 a.m. to 2 p.m. but the cultural evening is from 3 p.m. to 9 p.m. So you can understand how much importance we are giving to the cultural evening in that UConn. So I would request all of you to register, and now I would give the mic back to our secretary. Thank you.
Thank you, President Dr. Meenakshi Deshpande, madam. A very good morning to all of you. I am Dr. Gitanjali Sharma, Honorary Secretary of IMA Pune. Dr. Meenakshi madam said that for this diabetes course, we crossed the borders of Maharashtra. Let me just correct her that we have not just crossed the borders of Maharashtra, but we also crossed borders of India, because we had 3 delegates, 2 from Malaysia and 1 from Saudi Arabia. They are IMA members, they are Indian doctors, but they are working over there, and they showed the interest that they wanted to join this course. So we had 3 doctors, and because we had one condition, they had to send 5 cases for us, and because somebody is there and they are into some other field, when they go abroad, they may not be into clinical practice. So they expressed their wish to accept, their presence without cases. So we have accepted, but I just wanted to say that. So IMA Pune has gone beyond Indian borders. Yeah, later on we'll just. So today is the final module of our diabetes course and diabetes food workshop, and I am so grateful to Dr. Arati Shahade madam for organizing this fantastic course and this workshop in association with Diabetic Food Society of India. So to start the session, may I now request to chair the session Dr. Behre sir and Dr. Mantri sir to come on to the dais. Both of them need no introduction. Dr. Behre sir is a well-known surgeon from Pune. He has been past president of Pune Surgical Society, past president of IMA Pune. He has been secretary of IMA State. He is a medical legal expert. In fact, he is the founder of medical legal cell of IMA Maharashtra. Dr. Mantri sir is a very senior family physician from Pune. He practices in Kothur for more than 40 years, if I'm not wrong. He has received many awards as the best family physician from Rotary. Also, he has got Puraskar. So, without taking much time, over to you, sir, and we'll start today's CME. So, the first speaker, first faculty for today is Dr. Manisha Singh. and she will be speaking online on relevant anatomy about diabetic food. Dr. Manisha is the Associate Professor of Surgery from Gajraja Government Medical College. She has done fellowship in diabetic food from Amrita Institute. She is very much academician and research-minded person. She is pursuing her PhD, and she has published a lot of papers at national and international journals in peer-reviewed journals. So, welcome, Dr. Manisha from IMA Pune, and over to you for your talk. She has joined online, so let's hear her talk. Thank you. Okay.
Hello. Very good morning. Let me thank IMA Pune for giving us a positive of the session. And let me I congratulate Mr. Deshpande madam, Arti Shah madam, Vital Sharma madam,
ओपन कर ले
before going to actual session diabetic food is food that exhibits pathology which occurs as a direct result of diabetes mellitus or its chronic complication. Diabetics are predisposed to food infection because of a combination of factors. These are similar to diabetes, local trauma or pressure, lack of sensation because of neuropathy. Diabetic food has a wide range of presentation, right from breaking skin to chronic osteomyelitis. Thus, it is a mixture of pathologies including diabetic neuropathy, peripheral arterial disease, cardiovascular arteriopathy, food infection, and osteomyelitis. So, with these remarks, I request Manisha madam to proceed forward. Thank you.
Thank you, sir, for that introduction. Can you all hear me? Hello? Can you hear me?
Yes, madam. We can.
Yeah, thank you for that introduction. And it's indeed an honor to be a speaker at such a prestigious forum, IMA Pune. And I specifically thank Dr. Arti Shahde for inviting me to this course and as a faculty speaker. So without wasting much time, I would directly switch over to the relevant structural anatomy and the functional anatomy of the foot after diabetes, and how does it affect the locomotion. So shall I start sharing screen? It's already started. Yeah. Full screen. So I hope you can see that. Hello?
No, we are not able to see your screen.
They are not able to see our screen. Can you hear me? Can they see it? Okay.
Yes, it's visible.
Okay. So I would be speaking on the relevant functional anatomy of the diabetic foot. Specifically, once the diabetes occur, how the foot shows the various changes. And we would be talking about the diabetic neuropathy and tissue glycosylation and the various changes which follow. So we have come a long way from the crudest possible treatment given in the 19th century to the diabetic foot under the influence of alcohol or the minimum anesthesia and the crudest, most septic procedure. So at present, we have a huge challenge, and we need to look double the number of feet to address. And with 2 lakh amputations every year due to diabetes, and 85% of the high-level amputations are on account of the infected neuropathic ulcers. However, these can be largely preventable, and this is the reason that we think of food salvage and diagnosing it early. So these are the devastating changes which occur in a diabetic foot. A single visit by a diabetes patient to a, I hope you can hear me.
Yes, yes.
Okay, so a single visit by a diabetes patient to the podiatrist before this complication of the foot ensures, every year annual survey or the annual checkups, it can save a lot, save the foot and save the money. So we can say that it has a huge socioeconomic impact from the disability and from the economic point of view. And every 17 seconds, someone is diagnosed. Every 30 minutes, a limb is lost to diabetes, and every 20 seconds is lost due to landmines. And every 20 seconds, a limb is lost to diabetes, even quicker than the landmine. So we really need to look at it. So foot is a marvel of mechanical engineering, and it's a masterpiece. And it's a complex and strong mechanical structure with 26 bones, 29 joints, approximately 30 joints, and more than 100 muscles, tendons, and ligaments. So it supports the body weight, and during the standing, various other activities, jogging, jumping, and even during the walking. The feet arches, they serve a main purpose. They help to fit into the even or uneven surface of the ground. They act as shock absorber during the various activities. And the linear relationship between diabetes and foot morphology is due to the neuropathy which is occurring as a result of diabetes. So from the quadrupeds having the gripping ability in orthograde bipedal gait, we have now come to the orthograde bipedal gait from the monkeys to the human beings. And this is the changes which have occurred in the foot as a result of the ability to support. So we can see that we have developed a larger heel. The ankle is adapted for walking. There's a stiff midfoot in the stance phase for effective propulsion, and adducted big toe compared to the grasping big toe in the primates. The human foot has cultural variations, and Indian feet have shallow medial arch. Shallow medial arch increases the medial mobility at the mid-tarsal joints. So these are the, it also serves the function of supporting the body weight, acting as shock absorbers, act as springboards for propulsion during walking and jumping. It can adapt itself to uneven surfaces. Long flexor and small muscles of the foot, they assist in the propulsive action. So foot is considered to be an organ with its own blood supply, nerve supply, and it is considered now as an organ. The pathobiomechanical changes in diabetics, they occur due to advancement of the peripheral neuropathy, and this is the main etiological factors. And the non-enzymatic tissue glycation occurs irreversibly in the tissues, the proteins of the tissues. This glycosylation is due to the abnormal ages-related product which occur as a result of abnormal glucose metabolism pathways activated in diabetes in the background of hyperglycemia. They actually alter the mechanical properties of the connective tissues and reducing their elasticity. The skin becomes more thick and less elastic. The collagen bundles in the dermis, they also are thickened and disorganized. And there is definitely a reduced activity of the collagenase, and remodeling of the collagen fibers is also very reduced and late. The glycosylation of the keratin in the stratum corneum of the skin, it impairs the results into the impaired pressure redistribution while walking. So it also causes thickening of the ligaments, muscles, the various facial sheaths, and causes stiffening of the joints, thickening of the tendons, ligaments, and the joint capsules, reduces the tissue flexibility, elasticity, and reduces the range of motion of the various muscles. So there are various research studies proving that it brings about a change in the biomechanical properties of soft tissues due to the ages-related product, and affects the integrity of muscles and the bones. The therapeutic effects of immunoguanidine, an inhibitor of non-enzymatic glycation, can be monitored according to this research model. So we know that the injury in diabetic foot, the injuries are due to formation of the abnormal bony prominences as a result of motor neuropathy and increased pressure at the level of motor neuropathy, giving rise to foot deformities, increased pressure underneath the deformities as it is force per area. So smaller area putting more force on that particular area, and with the repetitive acts of walking, it may be resulting in the breakdown of the skin tissue. The normal 600 kilopascals of pressure threshold is the skin threshold to breaking. So it may be crossed, and you at 600 to 1000 kilopascals pressure, the skin may give way, resulting in the formation of the ulcers. So the various forces may be normal or perpendicular to the body surface, or shear, that is tangential to the body surface, which may be vertical, or also called as the shear forces, which are side to side. Impulse loading is more relevant than only high pressure, and impulse loading is the product of the pressure and the ground contact time. So in diabetic foot, the ground contact time increases. As a result, the impulse loading is more, and then this results into the higher pressures. So we can see that the anoxia and ischemia in non-diabetics, the patients during the normal act of walking can recover from the anoxia and ischemia almost instantly. And in diabetics, there is a delayed recovery from this anoxia and ischemia, leading to inflammation, warmth, and erythema inside the foot, which may present as blisters, and the blisters may break down to form an ulcer. The ulcer in turn may get infected and pave a road for amputation, which has increased mortality. The sensory neuropathy in the diabetics leads to loss of sensation, inability to feel the increased pressure, loss of position sense and the proprioceptive pathways, changing in the or the altered gait or the changed walking pattern, and hyperpronated foot. The motor neuropathy in the, as a result of diabetes leads to muscle imbalance and weakness, formation of deformities, changing in walking pattern, elevated plantar pressure, increased ground first MTP contact time, and hyperpronated foot. So the apart from the neuropathy, the peripheral vascular disease and macroangiopathy also contribute. Amongst the neuropathy, the autonomic neuropathy results into absence of sweating or the reduced pseudomotor function, impaired blood flow regulation, dryness of the skin, formation of plantar fissures, formation of callus and hyperkeratosis. The foot ischemia due to peripheral vascular disease and macroangiopathy leads to foot ulceration in the background, which may get infected and leaves and is responsible for amputation. So majority of diabetic foot ulcer are in the region of first MTP joint, and as we have just talked in the previous slide, they are more from inside out. We can see the displacement and thinning of the plantar pad of fat as a result of neuropathy with hammer toe deformity, and the metatarsal head is lying bare, and just underneath the skin it can be palpated, and it is exposed and hence more liable to get ulcerated on walking. So the various local factors contributing for the formation of the ulcers may be peripheral neuropathy, structural foot deformities, trauma, callus, history of prior ulcer, amputation, elevated plantar pressure for long period, limited joint mobility. Apart from the uncontrolled hyperglycemia, increasing duration of diabetes, presence of peripheral vascular disease, old age, and retinopathy and immunopathy. So we can notice dryness, turgid veins, nails, hard, brittle, and with loss of hair on the skin, redness or the flushed appearance of the skin, the fungal infection in the web spaces, calluses, and corns. And we must actually make an attempt to examine all these at the respective places to see for changes of the neuropathy in the foot. So the biomechanical consequences of diabetes mellitus may be foot ulceration, unsteadiness of the gait, uncertainty of the gait, higher impact energy dissipation, bones with inferior biomechanical integrity, increased thickness of tendo Achilles or the contracture of the tendo Achilles, which puts more forefoot pressures, and increased thickness of the plantar fascia, and the windlass mechanism becomes weak. Human foot, human foot cannot be studied in the animal models or the experimental models, as they are not appropriate, and they may have significant limitations. The human foot is unique, and it cannot truly, the experimental models cannot truly reflect its dynamic nature, and computer simulation motion capture imaging allows some degree of gait analysis, but it's not precise or not a detailed analysis, and hence human foot cannot be replicated in any study model. So we can see that loss of the forefoot due to as a result of the neuropathy, and it can be this partial foot amputated stump can be correlated with poor biomechanics irrespective of the level of the amputation. Even if it's a toe amputation or it's a transmetatarsal or a ray amputation, there will be some biomechanical deficit despite of giving a corrective orthotics prosthetics to the patient. And this biomechanical instability, it leads to recurrent ulcers and also elevated plantar pressures. And it definitely needs a tendon balancing procedure, because loss of tendinous attachment through amputation, it may lead to overpowering by the opposing muscle group. The shortened foot also leads to decreased overall efficiency or functioning of the foot with global imbalance, and may result in fall, needs assisted walking, and there are chances of recurrence. And decreased efficiency it also foot efficiency also increases the cardiovascular load. So the goal of limb salvage surgery when performed should be is to preserve the tissues, as well as it should be made functionally viable. We can human foot is, as I said, it has 26 bones. Ligaments, amongst them the deltoid lateral spring ligament, long plantar ligament, short plantar ligament, the very powerful spring ligament and deltoid ligament, which have a great role in the propulsion. The deltoid ligament, they stabilize the foot while the foot is marching forward. The arches of the foot, they are the medial arch, the lateral arch, the anterior arch, and the posterior arch. The medial arch is higher, more mobile, resilient compared to the lateral, which has limited mobility and is built to just share a part of the weight. It is low lying also. So we can see that in the medial arch, it is made up of calcaneum, talus, navicular, cuneiform, medial three metatarsals, and the plantar aponeurosis, flexor digitorum brevis, abductor hallucis, tibialis anterior, posterior, and flexor hallucis longus muscles control it. The lateral arch is formed by the calcaneum, cuboid, the lateral two metatarsals, with the lateral plantar aponeurosis, abductor digiti, mini, peroneus longus, and brevis muscles. The transverse arches formed by the 2 feet. The arches, they help in the distribution of body weight, they help in walking, act as shock absorber. The concavity provides protection to the soft tissue and the vessels in the sole of the foot. The veins of the foot, like great saphenous, short saphenous, and the deep venous system, comprising of the femoral, popliteal, peroneal, tibial, and the plantar veins. It's richly supplied by dorsalis pedis artery. Posterior tibial artery constitutes 85% of the supply. Dorsalis pedis artery may be inconstant, present in 10 to 14% of the cases. The medial and lateral plantar arteries, they form the muscles, the foot arch, the major supply to the foot, and they form a plantar arch, continuation of the lateral plantar arteries. So the innervation to the foot is through medial and lateral plantar nerves, which supply the musculocutaneous and articular branches. The diabetic polyneuropathy is frequently encountered in type 2 diabetes and increases from 8% newly diagnosed to 40% over 20 years of the diabetes. It can cause great disturbances with foot drop, and sensory symptoms and deficits are more frequent. Motor neuropathy symptoms are less dramatic and present late. There may be defective proprioception. The weakness of extensor and flexor muscles of the ankle and the knee extensors is related to the severity of the neuropathy. It may lead to the poor balance, coordination, and the pathogenesis, important causative factor in the pathogenesis of diabetic foot ulcers. The motor neuropathy leads to clawing of the toes, the hammer toes, the mallet toes, the raised arch of the foot or the pes cavus, the foot drop, intrinsic minus foot or the intrinsic muscle wasting, and presence of deformities. Autonomic neuropathy reflects in dry skin, fissuring, distended dorsal veins, a warm, well-perfused foot with increased blood flow, and the bounding pulses. So in this fit, we can see in this pic, we can see the ulcers under the plantar surface of the big toes. Initially, they had the callus or the hyperkeratosis in these areas due to elevated plantar pressure under the foot deformities as a result of muscle intrinsic minus foot. Hyperkeratosis patterns related to some biomechanical alterations occur at the first, second, and the first, second, third, and the fifth metatarsal spaces or the walking surface of the foot. The hallux valgus and the hallux varus, they arise as a result of crowding of the toes and the motor neuropathy. The extrinsic muscles of the leg, they insert their tendons into the foot, and we have the various intrinsic muscles originating and inserting in the foot itself. The sole has 4 layers. And in this study, we found that the muscular atrophy underlies motor weakness at the ankle in diabetic patients with polyneuropathy, and the atrophy is more pronounced in distal compared to the lower leg. So hence, it's more of a length-dependent neuropathic process leading to motor dysfunction. In type 2 diabetic patients, they also may have muscle weakness at the ankle and knee related to presence and severity of the peripheral neuropathy. Intrinsic muscle atrophy and toe deformity, it is said that the sensory neuropathy is often emphasized, that the consequences of motor neuropathy in the feet are more profound in people with diabetes. And it is not necessary that the presence of intrinsic muscle atrophy must necessitate a formation of a toe deformity. The extensors are dominant. We have a hammer or retracted toes, and with the dorsal ulcerations. The flexors are dominant. Then we have the mallet or the clawed toes, and the lesions or the ulcerations at the apex of the toes or the tip-top toe syndrome. Clawed toes we can see, and there is hyperextension of the metatarsalphalangeal joint, flexion at the interphalangeal joints, crowding of toes, and hallux valgus deformity in the intrinsic minus foot, leading to fungal infections in the web spaces due to overcrowding of the toes. We can see the hallux rigidus or the limitation of the joint movement, the first metatarsalphalangeal joint, leading to limited or the increased pressure under the toes while walking. So the heel pad has and the plantar pad of the fat, these are normally thinned out in diabetes, and this there's also increased stiffness, and the shear force is also elevated. It compromises the ability to dissipate the stress and elevated plantar pressure underneath the heel and the plantar surfaces. So in patients with toe deformities, risk of plantar ulceration is high due to elevated plantar pressure. We can see that thickness ratio is high, is low due to the reduced thickness of the plantar pad of fat and forward displacement or distal displacement, leading and compared to the thickness under the phalanges, which is more. So the thickness ratio is less. So while patient is wearing a Hawaii chappal, which we use routinely in the household, they are trying to grip, and the gripping ability gets reduced due to weakness of the intrinsic muscles and the weakness of the lumbricals and the interossei muscles. and the presence of toe deformities. So the heel has separated fat pad with separated by the fibrous tissue, and there's a formation of chambers, or these fibrous septa give rise to formation of small locules in the calcaneal fat pad, and where this honeycomb configuration makes it very difficult to eradicate any infection in the heel, and very difficult to heal. So this stiffness leads to diminished cushioning capacities in the diabetic heels, where the heel pad, where the fat pad is the thickest. So the cushioning property is reduced. The plantar fat tissues, or the tissues below the calcaneus, they are reduced. Energy loss is more compared, and with a decreased modulus of elasticity. So the sole of foot has 4 layers bounded by which act as cushion in the foot and protect the vital layers, or the vessels and the nerves and the muscles. In cases of limited joint mobility as a result of non-enzymatic tissue glycation, the tissues around the first metatarsophalangeal joint, which comprises of the base of the proximal phalanx, the metatarsophalangeal joint, the joint capsule, and the 2 sesamoid bones. The tissues in the periarticular area gets thickened. There is calcification, or sorry, there is stiffening of the tendons and the ligaments. So the plantar fascia also gets inserted near the first metatarsophalangeal joint and the various lesser metatarsophalangeal joints. So the rupture of plantar fascia may occur due to glycosylation changes, and the loading pattern of the foot changes. To explain it, there is a windlass mechanism wherein we can see there is flexion of the toes or the interphalangeal joints, which occurs whenever there is a contraction of the foot, or if the foot is in the stance phase of walking. So the whole triangle, which is formed by the medial column, it gets contracted and lifted up, and then the toes also flex. So this is important in walking and in the stance phase. But what happens in diabetes, the elevation of the medial columns is reduced, and also there is limited joint mobility at the toes, around the toes, which leads to deficient protective windlass mechanism and difficulty in walking. The pes cavus, or the high arch foot in the neuropathic, is the foot size does not change with the age, but however the shape changes. There's the foot space inside the plantar surface is divided into various compartments by the rigid, by the fascial sheets, by the various rigid bony structures and the muscles. And here the arteries and the vessels, they are packed in tight compartments. So there are medial, dorsal, plantar compartments and the lateral foot compartment. So we can see the contents of these triangles are the various muscles and the arteries. So any infection which is or any arteriosclerosis or the advanced septic arteritis, occlusion of the plantar arch of the blood vessels occurs, leading to the formation consequent to the plantar abscess which occurs, or extension of the web space abscess. So this pus gets trapped here, and then it occludes the nearby vessel due to septic arteritis, and there will be local gangrene of the toes in the presence of the proximal palpable pulses. We can see the clinical picture. The patient has a well-perfused foot with the palpable dorsally posterior tibial, but there is presence of wet gangrene as a result of septic emboli in the vessel. So foot infection spreads along the extensor tendons in the dorsal ulcers and along the flexor tendons in the plantar ulcers. The infection from the foot ascends up the leg, and we can see that the various extension of the foot needs debridement and coupled with amputation. So the normal walking cycle or the gait is comprised of the initial contact, the forefoot contact or the stance phase, heel lift, and the toe off phenomena. The 68% of the cycle is the stance phase. So heel strike is the initial contact or the first, followed by the forefoot contact or the stance phase. And this is when the foot is undergoing a heel strike and begins locomotion, then takes up the stance phase, or it is in contact with the ground, and then the toes are lifted off the ground. The other feet is swinging in the air and is about to begin the heel strike. So 32% of the cycle is the swing phase and 68% of the cycle is the stance phase in the two different feet. So it is a repetitive pattern which is involving steps and strides. Step is one single step and stride is a whole gait cycle. The step width is the mediolateral space in between the two feet, and the time from one heel strike to of one foot to the heel strike of other foot is the strike time. So we can see how the heel strike followed by stance, starting of mid stance, then the toe off finally. You can see the mid stance phase, and then the heel lift, in which the tendoachilles and the gastrocnemius muscle complex works, and the pressure comes on the toe, and finally the toe off phase. So in diabetes, pronation and supination in the heel strike is there, and the heel is not balanced. Increased ground contact time in the first metatarsalophalangeal joint, which is the reason why majority of the foot ulcers in the forefoot occur at the first metatarsalophalangeal joint. The shear force increase at the third metatarsalophalangeal joints, leading to the presence of hammer toe and the ulceration at the metatarsal head. Supination heel strike causes fifth MTP joint callus. So biomechanical loading in diabetic foot leads to formation of deformities, abnormal walking pattern, limited joint mobility, repeated plantar pressure, and the shear stress that is generated, which may lead to the repetitive forces of walking may cause the damage to the tissues, and also it leads to the formation of elevated plantar pressure and leads to the formation of ulcer. This picture shows the windlass mechanism. Occurs when the dorsiflexion of the first metatarsalophalangeal tightens the plantar fascia and supinates the medial arch. So whenever there is supination of the medial arch, the windlass mechanism should occur when the swing leg phase passes the stance leg. Leg externally rotates, heel lifts, and the foot supinates to create a right lever or the firmness of the midfoot for forward propulsion. Problems occur when timing is incorrect or force requirement are too high. So in diabetics, due to the weakened tendons and the ligaments, it may be difficult to have a good windlass mechanism, leading to generation of increased forces or elevated plantar pressure underneath the forefoot areas. So impulse loading is more irrelevant than only the high pressure. 85% of the ulcers are within out. Repetitive moderate force of even routine unprotected walking without footwear can damage the feet in diabetics. Hence, they have to use the suitable footwear during the normal walking, even inside the house. Foot is most energy efficient, means this energy efficiency is lost in diabetes due to presence of neuropathy. In diabetic patients, the walking is slower with great step variability and higher plantar pressure. Diabetics, they actually walk slower than the non-diabetic controls. Altered gait patterns during obstacle crossing can be seen in this. Despite a significant reduction in the passive range of motion at the ankle in diabetic group, the gait range of motion was indistinguishable from the reference subject, and it was correlated with peak or the elevated forefoot pressure, suggesting that at the metatarsalophalangeal joint, the range of motion at peak forefoot plantar pressures are higher at the first metatarsal phalangeal compared to the ankle joint. Limited joint mobility.
Then can you conclude your talk, please?
Yeah. In just, I think 2 or 3 minutes, I will conclude the talk. So, limited joint mobility in diabetics and aging is degenerative joint disease, increased stiffness of the collagen tissue, and due to non-enzymatic tissue glycation in the diabetics and with deposition of the ages-related product, which in turn leads to increase in the collagen crosslinks. The plantar soft tissue under the metatarsal head in diabetic patient endures high dissipated energy during walking. This may be responsible for tissue breakdown or the ulceration in diabetic patient. In hallux rigidus, as I have spoken, first metatarsophalangeal joint as a result of limited joint mobility due to non-enzymatic tissue glycation. And we can say there that to relieve the forefoot pressure, tendon-Achilles lengthening may be required, tendon balancing may be required, reduces the forefoot and midfoot pressures. The Achilles tendon contracture is the first thing to occur in an equinus deformity, increases the plantar forefoot pressure, and increases the risk of ulceration. We can see the various range of movement, plantar flexion, inversion, eversion, supination, pronation, dorsiflexion, which are all limited range of movement in the diabetic foot. Charcot foot, it occurs due to the breakdown of the midfoot as a result of repetitive forces of walking, with major force, major pressures occurring in the forefoot and the midfoot area, especially when as the heel lift occurs and this defective windlass mechanism. You can see the breakdown of the midfoot, the Charcot foot with the abnormal deformed foot. Neuroarthropathy occurs in 60% in the tarsometatarsal joint and 30% in the MTP joints, 10% in the ankle joints, more common in the tarsometatarsal joints. So we can use the pedoballographs to measure the plantar pressure and the modern gait analysis machines to monitor the gait. You can see the various amputated foot and the foot deformities, making a high elevated plantar pressure and liable to ulceration. Faster the gait, higher is the pressure. Longer the stride, then more are the pressures. So adequate and proper understanding of diabetic peripheral neuropathy and altered biomechanics is essential for preventing higher level amputations. And what the brain does not know, eyes cannot see. So we should know the exact foot anatomy before considering the surgical treatment of the patient. So protection of high pressure areas in the foot and the corrective footwear or the supportive arthrotis is the only strategy to prevent the footwear. And the biomechanical assessment involves the range of motion assessment, manual muscle strength testing, the proper grade analysis, static and both dynamic before and after the limb salvage procedures, and giving the prosthetic and the custom accommodative footwear or orthotics. Knowledge of foot anatomy and biomechanics cannot be overemphasized, and it prevents definitely the higher level amputation in the diabetics. Many changes in structure and function in diabetes occur, and muscle atrophy of intrinsic and extensive is notable and progressive. Diabetic skin and plantar tissues are thicker and stiffer, and gait is slower, more variable, and obstacle clearance is less. So the diabetic feet always cry for help, and we have to look at them, never miss a foot examination, and salvage them. Thank you for the patient hearing.
Questions and answers.
Can we take the question and answers at the end of the session, please? We can have the second block because we are slightly short.
Insert we conclude. Thank you very much, madam, for your explanation.
I can hear very less. I can hear very less.
Yeah.
Volume is not good.
Yeah.
Madam, your voice is.
Yeah, now it is good. Now it is good.
Yeah.
Can you hear me?
Yes, madam, we can hear you. It was an excellent talk. And we appreciate if you can wait online because we'll take question answer session after the pathophysiology and examination.
Okay, ma'am. Okay, ma'am. Thank you, ma'am. Thank you. 23.
Now we go to our next slide. My dear friend, Dr. Aarti Shahade, madam. She is MBBS and MD General Medicine, graduate diploma in diabetes care and consultant physician and diabetologist. She has worked in diabetes and endocrinology unit of St. Thomas Hospital, London. Worked as a consultant diabetologist in KEM Hospital, Pune. She has been examiner for Pune University Health Sciences Department and DNP teacher and guide for Pune Hospital. She has received many awards, including a few are Best Poster Prize in RSSDI 2015 for remote monitoring of diabetes and intervention. The mobile application conceptualized for this purpose is unique and one of its kind. Poster on maternal hypoglycemia and fetal outcomes in ATTT Berlin 2019. Paper on hypoglycemia and lipid profile in International Journal of Current Medical and Pharmaceutical Research in October 2018. And poster on new device to measure food temperature in diabetic food in ADA 2019. I think this is just the formal introduction of Dr. Aarti Madam. We all know her. She is the best academician, the best teacher, and she's the main faculty designing this course of IMA Pune online certificate course on evidence-based diabetes management. So over to you, Dr. Aarti Madam. Welcome to IMA.
Can you hear me? Can you hear me, sir? Thank you very much. So all of you, very good morning. All of you can take a deep breath. I've got an announcement to make, very important one, that there will be no exam after this. And yes, yes, and then we also have one more announcement, and that whatever number that was locked yesterday will be unrevealed today. So be prepared for that. And to many, I think it is, especially Padma Madam, like people, it's very important. Probably it is more important than what is happened to the dollar and the gold, etc. So those numbers matter a lot to them, right? So yeah, you can hold your breath till then, ma'am, right? Okay. Thank you all of you for being here on a Sunday morning. Sunday mornings otherwise can be a bit painful. And yes, Manisha did a lot of job which I should have, I'm thankful for. Yes, we know that every 20 seconds there is a gentleman or a lady diabetic who's losing her foot. In fact, that is one of the most important reasons why we are here, irrespective of whether we are family physicians, irrespective of whether radiologists or diabetologists, gynecologists, or whatever that is. So many millions of feet. In 2035, it will be something like 635 million diabetics, and then double the amount of foot, and then you have got at least a quarter of them developing foot problem in their lifetime. So that makes it about not less than 4 to 5 million. Well, this is a very, what should I say, not a restrained number, it's a very conservative number. So many millions of feet, right? And then you need to actually prevent so many amputations. So it's important for all of us to be prepared mentally and from the point of view of education to see how best we can prevent. Can we actually prevent everything of this? Very unlikely. That is because neuropathy or the microangiopathy is a function of the duration of diabetes. So the whole problem is that our diabetics are getting diagnosed at younger and younger age. So you have a 21 and 22-year-old coming with diabetes. So 20 years down the line, these people are going to develop microangiopathy, even if I keep his HbA1c at 6.5 all the time, right? And then all these problems are bound to start. So this workshop is for the present problems, but remember, this is also for the future. So we need to be geared up to actually manage all these patients and try and prevent as much as possible. So this is important. Now, second, now looking at the feet, where are they likely to occur more? They're likely to occur more at the toes, either on the dorsal side or on the plantar side. The second commonest area is at the head of the metatarsus, and the third is at the heel. So epidemiologically, these are the important areas where you are likely to get more number of ulcers. Right? We all have learned about microangiopathies, etc. So I won't be going into detail of the slide again. Yes, there are two very important reasons for diabetic foot. One most important the reason is diabetic neuropathy. As I told you, this is more or less, not completely removable, preventable, treatable, at least in the present circumstances. If we can do it sometime in the later, well, that's ideal, right? Yes. So first one is neuropathy. The second one is ischemia. That is peripheral arterial disease, right? Peripheral arterial disease to a large extent can be managed. It can be managed, like say, with the present interventions and drug managements that we are employing, we are able to treat a couple of patients because of that. Of course, not very great numbers. Right? Now coming to the neuropathy. Like how Dr. Manisha said, it is the neuropathy that is responsible for the beginning and the end of this saga. This is a picture which I like the best. Okay, this is a picture which is given in most of diabetic food textbooks because it's visually very appealing. Look at the normal nerve. 1 minute. Yeah, this is, can you see my pointer? That's the pointer. Yeah, this is a normal one. Look at the blood vessel that is supplying the nerve. Look at the diseased nerve, a diabetic nerve, right? It is shrunken, it's got more fibrous tissue. You can see that the axons and the myelin don't appear to be normal, and you can see that the vessel is almost occluded, right? And it is this occluded artery that produces intense pain, anesthesia, right? Anesthesia, hyperesthesia to the patients, right? So neuropathy has got 3 components: motor, sensory, autonomic. Right? So what does motor neuropathy do? Motor neuropathy produces the weakness and the wasting of the intrinsic muscles. It is the intrinsic muscles which are responsible for maintaining the arch, maintaining the bone alignment, etc. So when you lose it, naturally there will be foot deformities. Depending upon the interplay between the flexors and the extensor, different kinds of deformities will occur. And that will be responsible for abnormal gait, and it will be responsible for the changes that will occur when the patient walks, that is the foot pressure will be not evenly distributed as we see in normal individuals, but it will get distorted. So the high pressure areas are likely to break down. And that is the one which will produce the ulcers. So this is simple. You can see that. In fact, you can remove, you can feel your own feet. There's a big patch of fat underneath the first metatarsal. If there is a deformity, what has happened? The pile of fat has moved forward and it has laid bare the first metatarsal joint. So the metatarsal joint just rests on the thin skin, and then all your weight will fall on that. So naturally the skin is going to break down and the ulcer will be produced. So this is the way neuropathic ulcer will appear. So it is not that it is required that there has to be a trauma for the ulcer to occur. Okay, the trauma may be trivial. It might not even be present. That's what Manisha said, that this is an ulcer which breaks out from within and not from outside. So that is the difference between other ulcers and neuropathic ulcers. Sensory neuropathy, what does it do? Sensory neuropathy takes away the greatest gift of God, and that is pain. So patients will not understand that there is some danger. They'll put their foot in a hot water bath and get it scalded. They will put their foot on some thorns and then there is naturally break in the skin, the barrier skin, right? That is lost. So the pain is lost and that leads to all of the problems. And what else does happen? Autonomic neuropathy. You see, many of our diabetic patients have got very dry skin, correct? What does this dry skin do? It builds up a lot of callus. The callus will break down, and when it breaks down, naturally the skin will become open, and with the patient walking on that foot, in the abnormal position and the pressures being on that callus, again, it will lead to formation of the ulcer. Well, that's not just all. You can see that there are lots of fissures, right? It's not all. It does one more thing. That is, it deviates the blood supply from the capillaries. The adhesions get open, so the blood flow doesn't reach the capillaries. From the arterioles, it just enters the veins. So there is ischemia of the tissue. And it is this ischemia which adds to the problem. So pathway, first you have neuropathy, you have a trauma, then you have an ulcer, and on top of that, what you have is you have got changes in the other tissues like tendons, muscles, then joint stiffness. So usually when we were students, it was said that ask all your diabetic patients to do one test, and that is prayer. So if the patients are able to do this, that means their joints are normal, their tendons are normal, their soft tissue is not. Okay. But if it's a long-standing diabetic, they won't be able to do it. They will be able to do it only so much. Okay, this is known as prayer sign, right? So that is to find out whether the tendons, the muscles, and the other fibrous tissues involved or not. Right? So there's a lot of joint stiffness in the feet, especially that of the first toe, and that is hallux rigidus. So the next speaker, Dr. Amit, will show you how to examine and the importance of it. Because when your foot takes off, right, it is the flexibility of this first toe that is very important. If you lose it, then naturally everything will get distorted. In addition to that, as Manisha said, because of all of these, the gait changes. There is a lot more time spent with the foot on the ground. So when the foot is on the ground, the weight is all on the foot. Naturally, the ischemia will get more, right? And then because the increased pressure, the skin becomes more susceptible for breakdown. So the gait changes are there, which you can make out on pedopadography, which we will show you. Okay, this is simple. This is a very beautiful picture. Look carefully at the first row. Look carefully how the pressures change from first contact to the flat foot, the foot flat phase to the terminal phase of the takeoff of the foot. Look at the Charcot's foot. That is the ultimate of a diabetic foot. Correct? These are the changes that are exactly the opposite of the normal. Right? So this picture is only to show you about the changes in the pedoparograph, which you should be able to pick up. The last but not the least one. We also spoke about, just 1 minute, I'll go back. Yeah. We also spoke about infection in last few classes, correct? It is the change in the response to the infection, change in the immunity that is also responsible for perpetuation of an ulcer. Okay, I'll come to that later. Now, Dr. Amit will next teach you about the symptoms, how you'll have to pick up the early stages of neuropathy. And then he will tell you about how to examine, including the pressure sensations, vibrations, etc. Okay, and he'll also show you how to use a biothiometer, temperature sensations, and also the ankle reflex. This is very important. Now, regarding the peripheral arterial disease, remember, it is worse than the triple vessel disease. That is because triple vessel disease to a large extent today is treatable, whereas in the leg, the patient has to undergo amputation. Dr. Kotulkar today will teach you about the peripheral arterial disease, and Dr. Amit will teach you about how to pick up the early signs of insufficiency of arterial supply. Now coming to, as I told you, infection. Well, the healing is impaired in these patients. And because of the impaired healing, these patients will tend to have an infection or an ulcer, which is ongoing, doesn't heal very fast. Correct? Not only that, they end up developing different kinds of microbiological population. So starting from gram positive to gram-negative organisms, especially when they go to the hospital again and again. There is a very, very real problem of multi-drug resistant organisms making home over there. And there is a biofilm formation, which adds to the problem because the antibiotics, topical or not, they will never reach the wound base, right? So these patients, when they develop biofilms, they're expected to undergo debridements again and again. So you make a chronic wound, convert it into an acute wound. So what happens is the acute wound has got more likelihood of healing, correct? So these patients have to undergo debridement again and again for the healing to occur. So this will increase their expenses. Don't forget that, right? So in all, it is neuropathy, deformity, minor trauma, and poor self-foot care, right? The poor self or inadequate help or self-care is very important. And that is also because we do not teach our patients how to cut their nails. Many of them will cut too short. Many of them will cut so long or don't cut at all, so that they land up with nail problems, trauma, etc. Many of them are not able to reach, okay? As I told you, because of the joints and the difficulty in moving their limbs, etc. So they will not be able to reach their feet. And many of them also have retinal problems. Their vision is poor, so they cannot do anything about it. So usually we tackle these when they come to us on regular basis for their follow-up. So we need to see their foot. They will not complain of anything. Remember that. They will never say anything. It is your duty. So you start your physical examination of the patient from foot, right? So feel for the pulses, look at the nails, look at the web spaces, look at what has happened to the sole of the foot, whether it is dry or not, and then examine upwards, right? It is the duty of the doctor to see. Don't expect patients to complain about it. Only when you start doing it, maybe from every 20 seconds, it might become 21 seconds that we will be losing a foot. Okay, so this is very, very important. You need to teach our patients, educate our patients. But some of the teachings that we do are a little difficult to follow. They're not very easy to follow. That is because, as I said, the vision is very poor, right? So many of the times we ask the patients to use a mirror to see. Nowadays, we ask the patients to take a selfie. So they've got a selfie stick, so they can take a picture every day and see their own feet every day. So these technological advancements have helped us to some extent, but one needs to be tech savvy, right? So you cannot tell this to all our rural patients. However, we have made efforts to teach it to the attendants who come over there. All right. So, but then every time you have a different attendant. Ekda जावई येतो आणि एकदा मुलगा येतो. So, and half of the time they're not interested, right? So then you'll have to move them, shake them, and tell them, well, this is what you are supposed to do. Yes, when you tell 100 times, maybe one time they will be able to do it. Second thing is you have to examine their footwear. Don't forget about that. I'm sure Amit will cover that, right? Examination of footwear will tell you a lot more things which your examination of foot might not tell. It will tell you about the deformities better. It will tell you about the foot pressure, the way the pressure occurs the highest, how the patient stands, etc. So this is another important point, right? Footwear examination is very important. See, many of our patients will wear slippers. They will wear, some of them, the high-end society people wear the shoes which have got high heels. Either of them are not right. So you'll have to take a few minutes and teach the patients about the proper footwear, correct? That is again a very, very important thing. Patients are not expected to do some adventures like, home measures, right? So that also you need to tell again. So these are a few of the examples of bad self-care or footwear which we came across in our patients. So in total, last slide, sir. Diabetic foot, two major things, neuropathy and angiopathy, motor, sensory and autonomic. All of them will contribute, and they are responsible for production of the foot ulcer. This foot ulcer is going to get infected. The infection is not going to get better. You will go on doing, you will be doing a lot of debridements, and the wound refuses to heal. The wound refuses to heal, and then a day will come where you will have to make that decision to amputate the foot. So on this note, this is the last but a very important slide, which we should be actually convey this message to not only the doctors, but also to our diabetic patients, that if you do not want me to pay in large sum at the end, you probably have to pay small amounts intermittently to maintain the integrity of your foot. Right? Thank you very much. Thank you for your patient hearing.
Excellent presentation and enlightening us on
one question from
diabetic.
Just one
minute.
Audience. You want to ask?
No.
Yes.
Yes, sir.
We all know that neuropathy develops in adults at the time of diagnosis, and in children, the presentation is at 6 years, 5 years. Earliest we should look for.
Good question. 5 years. 5 years. In T1DM, usually it is 5 years. So usually you expect the microangiopathy to start around 5 years. That is why that is the time when we ask for an annual eye checkup, annual foot examination, etc. So for T1DM, it is at 5 years and annual after that, till such time that if patient has developed some problem, you might have to ask them to come more frequently.
We see that as a pediatrician, we never get even after 5 years.
Yes.
Because the nerves are in the developing stage, in initial phase.
Yes.
So earliest to look is after 5 years, that is theoretical thing. But practically, what is your experience in that?
Yes, sir. Many of them start having that problem when they have got the growth spurt. And remember, this is also a function of the length of the nerve. So when they suddenly become tall, naturally they start having this tingling, numbness, etc. So when they develop this growth spurt, so at around teenage time, they start developing these problems, sir. Neuropathy. But in children, yes, we recommend testing for it, especially eye, etc. at 5 years time. But as you rightly said, usually we don't see them till at least till teens. That is true.
What instruction we should give them while they are playing? Because we can't prevent their activities and even their plays.
Correct, agree.
What advices we should give to them?
Yes, very important again. So first thing is about the footwear. Correct, that they need to protect foot. That is very important. The children have to be told about that. Second thing is that as I told you, that they need to be very careful when they cut the nail, etc. And any change that they feel, maybe if it is becoming very dry, the building up callus, right? If the nails have undergone change, the skin has undergone change, then they should report to you immediately. These are few of the things which we keep telling the people. But as I told you, see, for them to recognize and come to you will be, that will be not very early. So you will have to check for it every time they come to you. That might hasten the process of, or rather early diagnosis can be made. Is that all? Thank you very much.
Thank you, madam. You have discussed this pathology thoroughly. So I think only this question was a practical question. So thank you very much, Dr. Vaidya. So now the next speaker is Dr. Amit Nagate. He'll be speaking on examination of diabetic foot. He's come all the way from Aurangabad. He's a DNB in family medicine, and he has done a PGP and CLD in diabetes, PG certificate and fellowship in diabetic foot care, and he's a organizing secretary in a Desicon 2006. He was rather, and he's a chief diabetologist and foot care expert at Nagate Diabetic Foot Clinic. He's a life that is in Life Multi-Speciality Hospital and Trauma Center at Aurangabad. So with this short introduction, I will hand over the mic to Dr. Amit Nagate. Welcome, sir.
Yes, this will be a live demonstration. So we are just arranging the sign. Till then, I request all the faculty and all the delegates that there is lunch. So everybody has to stay for lunch and also for the group photo. And I request all faculty to be there for the concluding session where there will be felicitation.
Good morning, all. I said good morning, all. Thank you. We have to be active. If we are going to have a workshop, then we have to be active, right? I have also had my presentation ready, but fortunately or unfortunately, my presentation is already told. So I feel that we should go with the demonstration straight away. What I will go on do is, I will just highlight some couple of points which have been missed in between. And till the stage is set, we'll go on with that. This is a very beautiful slide, which I love the most. Why to talk about diabetic foot? Why? Any guesses? Wild guesses? Any wild guesses? What is going to come up next? Yeah, lunch is next. That is true. But in for diabetic foot. This is a good show. Now, this is a scary one. Relative 5 years mortality rate. If you see, we have got firstly pancreatic cancer, the top. Second is lung cancer. Third one is peripheral arterial disease, which is contributing about 84%. Then we have got ischemic DFU, that is ischemic diabetic foot ulcers. That is the fourth one. Then comes the amputation, and then the diabetic peripheral neuropathy with ulcer, and the rest of the cancer, the breast cancer, prostate cancers comes down. So that is the main reason why we have to get our self updated to the management of diabetic foot and rest of the things. Why I am here? This is our patients. We have seen this. It could be our patient, it could be our relative, it could be our friend, it could be our known, unknown, anything. This is another presentation which is frequently seen. This is another presentation which are frequently seen. Yes. My eyes are up here. I literally can't see the feet. This is what it is. So we need to have a foot care. So this is a very beautiful slide. A podiatrist coming down, teaching you diabetic foot management or diagnosis, how to go upon for a diabetic foot. I must have went down to market. I should have stayed home. I should have bought something to eat. This is what frequently comes across. This is what we feel across. But for a diabetic patient, this is not the doctors we should come about. This is a slide which I would like you all to have a look. I am going to show you the new emerging phase of diabetes in India. This is this. Very scary. Various presentations of diabetic foot coming across. Very, very, very scary. Now this is a very wonderful slide. Diabetes itself tells you what we should see. D stands for deformity, I for infection, A for atrophic nails, B for breakdown of skin, edema, temperature, ischemia, callosities, skin color changes, everything is there. Only if you can spell diabetes, everything is there in your spell. Everything comes down. Whatever you want to see, what exactly is coming down, what kind of things are there. Main two causative factor, neuropathy, ischemia. Neuropathy is more common in our Asian subcontinent, whereas in Western, ischemia is more common. Sorry for this beautiful lady sitting down in the corridor. Very beautiful feet, beautiful ladies with beautiful footwears, but ill-fitting footwears. I'm really very sorry to say about this. If you can see, there are bony changes coming down. We have got pressure areas, rest of the things are coming up. This is the footwears which are coming out across. The right footwear on the right hand side, wrong footwear on the wrong side. This is what, if you see a wrong footwear, frequently nowadays we have got a concept of going with a pointed shoes. So this is what it happens if you see, if you have a pointed foot. Everything couples up, all the foots are coupling down. Hawaiian chappal, madam has already told. If you can see, if you can make out here, there is a deviation out here. Your toes or your toes are trying to hold the footwear, and because of that, the toes are shifting down, the pressure is shifting down, and you are having more problems. Yes. Now we can come down to the examination first point. Once the patient walks down to your OPD, what do you have to see? First, everybody is saying tendo Achilles, tendo Achilles, tendo Achilles. Fine. We go on with the tendo Achilles. What exactly we have to see? This is what we have to see. We have to see a pronation and supination. Supinations are inward turning, where your tendo Achilles is more lateral, outwards, and when it is pronation, that is, we have a flat foot or the pronated foot, then the tendo Achilles more medial. This is what this shows. This is what the slides comes down here. This is a Collingwood test. We usually don't perform this in our OPDs, so I won't be talking much about this. If we see a feet from behind, we see a too many toe sign. This sign specifically tells you about posterior muscles block which is there, and this leads to your more flat foot, pressure coming down to the medial side of the foot, and rest of the things are happening. This is what this is from the frontal view. Now the foot examination comes on. Can I have a mic and something which I can scroll up out? Moving mic there. आणि एक ह्याला स्क्रोल करा डायरेक्ट पॉइंटर तू उभं यस नमस्कार काय नाव आपलं साहेब संतोष वय काय संतोष सर 42 आहे काही आजार वगैरे तुम्हाला अजून तरी काही नाही ठीक आहे आज आपण शोधूया काही आहे का चालेल चालेल प्लीज बसा 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 याच्यावरती बसा याच्यावरती ठेवा एनीबडी कॅन कम डाऊन पाठीमागे घ्याल प्लीज थँक्यू काय नाही काहीच करत नाही येस सो व्हॉट वी कॅन सी इट इज ऑन झूम सो हे दिसणार आहे का
just 1 minute before I leave.
So first thing what we usually come across is, what we do is we see the leg, the structure, if there is some kind of hairy loss, if there is redness, warmth, erythema, what we do is we just go on and palpate in this way. Got someone, and then if you can see if there is redness, erythema, the temperature loss is there or not, the difference between the two feet, the temperature feeds, and then the rest of the things comes on. If we see that if there is a loss of hair at the first ray, that is the greater toe, the dorsal side, if there is loss of hair, then that indicates or that points towards your PVD, that is peripheral arterial disease. Next slide, please. Next, what we go down to interdigital spaces. We see out if there is any kind of a maceration comes down, what exactly it's there, Everything is fine here. Both the feet, if there is maceration or if there is kind of some element coming down, there is pus discharge, there is wet space or anything, so that comes down. Then next slide. Then we come down to the plantar aspect. What exactly the plantar aspect looks like? How the plantar aspect looks like? It won't go if I. Please come in the front and see. So on plantar aspect, what we see is the thenas, the hypothenas, what exactly it is. The medial arch, it is gone or not. We see, look for callosities, calluses, how exactly it is. If there is kind of any kind of bony prominences, what exactly it is. The toes, if the toes are, next slide. If the toes are hammer toes or not. For our nail, sir, एक minute, please. Nails, it is the fungal. If we have thickening of nail, what exactly the nails are, look like, and then the rest of the things. Next slide, please. The dryness of the skin. If there is kind of macerations beneath, what exactly it is. We usually, on Indian females, married females, we love to wear the rings, toe rings. So that can cause more damage, or that can lead to the local injuries, that can lead to maceration. So it's ideally preferred not to wear it. If the female, sorry, but it's from their point of view that they should wear it. But from medical point of view, if you want that the things has to be very clean, neat, tidy, then a diabetic female, long-standing diabetic female, if there is loss of protective sensation, one thing, if there is a peripheral arterial disease, those females should try to prevent it, not to wear it. Next slide, please. If there is an ingrowing toenail, the hammer toe, claw toe, how exactly it is. Anybody can point out this in this way? Camera in this way? No, camera in this way. नाही पण त्याला हे दिसणार आहे का? सर थोडंसं असं नाही इथंच राहू दे. नाही चेअर बरोबर असा ठेव पाय. एक 2 मिनिटासाठी फक्त पोझिशन चेंज करतोय. असा ठेव सही. हा पाय नॉर्मल ठेव. हा पाय असा करा. I want everybody to see here. It is coming up. That's कसा नाही इथं नाही नाही त्या पायावरती आहे म्हणून तो पाय दाखवतो. हा त्याच्यावरती आहे म्हणून मी दाखवतो. हा खाली आहे तो कसा पाहिजे. तू फिरून पाय दाखवून काय फायदा आहे का. असं आहे. हा ते तुम्ही सरकवा. क्लियर आहे. असं ठीक आहे. ठीक आहे. नॉर्मल सोड. रिलॅक्स सोड. सैल सोड. सैल सोड. सैल सोड. काही नको करू. सी देयर इज प्रॉमिनन्सेस हियर. ओके. हा टीम काढायला तिथे राजा. आता काय ते तू काय वापरतो. हा ते चप्पल. परत चप्पल. सी दिस इज व्हॉट वी टोल्ड. Hawaiian chappal. This leads to the previously second slide or third slide which has showed that the toes try to grip it and then the rest of the things happen. So you can see it. The individual is non-diabetic, non-hypertensive, of any kind of comorbidity, still he has developed it. So now you imagine if a patient, diabetic individual, uses this for a longer period, what is going to happen to them? Okay, next slide, please. The hammer toe, the claw toe, ma'am has already told, so I'm not going to go into detail of that. Next, please. Fungal nails, next. Yes. Anybody, I would like to have a comment on this. Anybody from the audience, what exactly it is? Corn. That is corn or a callus or a hyperkeratinized lesion. Anybody can see something is abnormal in that? Sorry? At the head of metatarsal, fine. That is there, that is the location of it. Anything abnormal in it? Punched out. Okay. Anything else apart from that? Did I hear? Sorry? No, fine, that is there. I heard something in between which is there, but some. Yes, there is a foreign body in the center. Next slide, please. See, I have removed the keratinized layer, the first keratinized layer. If you can see it in the center, there is a stone in it. Next. This is there. This is lucky for the individual. It didn't got infected. Lucky for them. So this is what it is. You missed out the things. You have to have eyes to see what exactly it comes in. Next slide, please. So this is our peripheral arterial disease. We have got pallor, pain, pulselessness, paresthesia, paralysis. Next slide. Yes. Here we have an absence of hair and a thickened nails usually. And we have got a dependent ruber with the dry and scaly skin, which is not there here. Next. Pallor, if we elevate the limb, and a ruber if we the limb is hanged up. Next, please. Yes. Sorry. See, from the first figure, we would ask the individual to just elevate. We have to measure this angle. We have to measure this angle. If this angle is greater than 15, that is normal. Below 15, there is a restricted mobility or the joint is stiff. Okay, early signs. Second, ask him to lift the toe. If this toe goes beyond 15 degrees, then that is normal. If that doesn't go beyond 15, then there is stiffening of the first metatarsal. Okay, that is halus rigidus. This, what exactly the point I want to say is that once we have got a claw toe or hammer toe, there is a pad of fat beneath the first metatarsal head that shifted upwards, and then the pad, once the pad shifts upwards, if you can see the down bottom one here, the pad is shifted. That leads to the cracking of skin if with a repeated pressure. Next slide, please. This is what we used to measure the angle. If it is greater than 15, it's normal. Below 15, it's halus rigidus. Next, please. Footwear ma'am has asked me, I've showed you one footwear with an abnormality right here. This is the second picture where if we have a straight creases, the last one, the crease are straight, the foot is normal. If the crease on a lateral side, then the individual is having halus rigidus. The other way, the pressure shifts down to the lateral side. So this is what you can just make out from your footwears, what exactly the footwear says you. Next slide, please. Yes, this is what this is the mechanism how usually a diabetic foot ulcers occurs. This is where the pad of fat shifts down. Then there is constant pressure. The skin breaks down, and then the formation of ulcers takes place. Next, please. These are the various pressure areas across the foot where you see where the pressures are maximum. Next slide, please. Same thing. Next. Yes. Now we come down to evaluation. This was just an examination, what we have to do. Now come down to evaluation. Evaluation comes down in two parts. One is a neurological evaluation. Second is vascular evaluation. Next, please. In neurological evaluation, sir, please. That's all I will say. This is a monofilament, 15 grams, 10 grams monofilament. What we have to do is, there are 5 to 6 points which are shown there. We won't be able to see from the front. Then I will be showing you from the back, from the side. If this is the first tray, this is pressed here, the buckling has to be in this. That's it. Not more than that. Not this way, not this way. The buckling has to be there. Once the buckling is there, that is the point when you have a maximum pressure and you get a prominent results of it. So what we do is, we ask the individual to close his eyes. Firstly, डोळे बंद करायचे मित्र. टोचणार नाही, काळजी नको करूस. We ask the individual if he feels it, if he feels the pressure. समजतंय? पक्का समजतंय? लक्षात ठेवायचं. लक्षात ठेवायचं. कशाला ते सांगतो. हे लक्षात ठेवायचं. दाब जो आहे, हे जो स्पर्श आहे, हा जो स्पर्श आहे, हा लक्षात ठेवायचा. किती पडला हा स्पर्श लक्षात ठेवायचा. खालच्या याच्यामध्ये स्पर्श कमी झाला का जास्त झाला मला सांगायचं. ठीक आहे. डोळे बंद करा. स्पर्श झाला नाही अजून. ठीक. डोळे बंद रे राजा. का बंद? चष्मा काढून तुला डोळे हे करायला लावायचे का? नाही ना. हा, डोळे बंद ठेव. So this is on the first tray. The buckling लागतंय नाही. धन्यवाद. हे बघ, इथं जसं प्रेशर आहे तसं नाहीये ना. बरोबर, थँक्यू. परत एकदा. नाही, स्पर्श झालाय पण वरचा आणि खालच्या प्रेशर मध्ये बदल आहे. खालचा कमी आहे, वरचा जास्त आहे. बरोबर, धन्यवाद. इकडे सारखंच आहे. इथे इथे त्याच्याहून कमी. ठीक. इकडच्या भागाला सेम आहे. इथे गुदगुल्या झाल्या आहे की नाही. बढिया. इकडे गुदगुल्याचे पण इथलं स्पर्श आणि हातलाचा स्पर्श सारखा आहे का? परत एकदा डोळे बंद कर. वरचा आणि खालचा स्पर्श सारखा आहे? कमी आहे? परत वरचा स्पर्श बघ. खालचा वरचा सारखा का? Okay, this is one test. Next slide. So, loss of sensation over the distal plantar surface to the 10 gram monofilament is a significant and independent predictor of diabetic foot ulcer and a lower limb amputation. So by doing a single test, you can predict if the individual is going to have a diabetic foot ulcer. Is the foot it as risk or not? It takes hardly how many seconds? 10 seconds, 15 seconds. That's it. Not more than that. Okay, please. Yes. Surprisingly. He says you don't have it. Surprisingly, there. First. that here जनरल लक्षात ठेवायचं. ओके कुठल्या लक्षात लक्षात ठीक जनरल लक्षात येते कोई अंदर येते ताकि वाली खाली राजा खाली जनरल है आणि ह्या जनरलमध्ये सेम मांडलेलं नाही ना आता आता तस इकडचा भाग तस आता now what we'll do is we'll go on with a documented evidence. This is the subjective evidence which we have with us. That is what we can do a bare minimum clinical setting. Then we have got a VPT. Next slide, please. Sir, this I have shown already. Please. Next. 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 Yes, this is what the VPT is. That is vibration perception threshold. There are minimum, we have to take minimum 3 readings. Raja? Yeah. So we are we have to usually have 3 readings, whichever the maximum comes of the 3, that has been taken care of. So the mean of 3 is taken into the consideration. If it is less than 15, that is normal. 15 to 20 volts, it's mild neuropathy. 20 to 25, moderate neuropathy. Greater than 25, it's severe neuropathy. So what we do is we set. So, okay. त्याला अनुभव करायचं का येणार मित्र सगळे हा सर म्हणजे त्यांना समोरच्यांना पण दिसेल थोडासा So now we will be testing on the vibration pressure perception with a machine that is called as VPT. If you can see, if you can see, this is the machine. You can find, you can focus it on the machine. Yes, right. Thank you. So the machine now is on 0. We gradually increase it. Once the individual sense the vibration, we stop. Okay. झणझणी येते की नाही तेवढं लक्षात ठेवायचं आणि तेवढं सांगायचं. Ali? So it is 1. So that is normal perception. Next. Second slide. Yes. This is 7.5. The perception level is normal. The vibration perception is normal. Okay? Sure. Next slide, please. This is a vibrator. What we can do is, it is around 1,000 patients can be done in this strip. That is reusable. 1,000 patients that produce a vibration. If there is a pinch, if you pinch it at the tip, where the tip is written, if you press it, the vibration sensations comes. If the individual feels that vibration, that is normal. If it doesn't feel it, the fit is at rest. Simple. Next slide. So now we have got a pressure areas. We have got 2 things. We have a Harris mat and a digital podogram. This is what we have with us is a Harris mat. This is what the Harris mat looks like. Next slide, please. There is a thin layer, a papery layer. Beneath the layer, there are macerations or serrations across the thing. What we do is we paint this with the ink. A paper is placed here. We ask the individual to put the feet on this. The pressure comes on. We have ink with us. Dynamic static. Next slide. So this is what the Harris max looks like. I will show you once it is there. Use next. Yeah, if you see, there are two circles which I've marked. These are the high pressure areas of the individual. Patimage. Thank you. This is the first. These are two high pressure areas which have been marked. So this is what ink has been applied. This is a paper which is kept in it. Now we'll ask the individual to stand on it. You won't be able to walk on it. Here, Mitra. याच्यावरती उभं राहायचं. कुठं लेफ्ट इकडे घ्यायचं अजून अजून ओके थँक्यू. याच्यावरती असा पाय ठेवायचा, हा असा उभा राहायचा, परत राहायचा, पाय हलवायचा नाही. जी मर्जी ठेव तुम्हारा बस चल उधर कर. थैंक यू. हा तुझ्या पायाचा ठसा. हा आता ह्या ठशामध्ये काय चुकतंय तुला सांगतो. करंगळी नाही आली बरोबर. अजून काय आलं? चांगलं वाटतंय का पाय? आपण ज्योतिषाला दाखवावं का? त्याचा काहीतरी ढुसलांमध्येच. हे बघ, हे जे काळं काळं दिसतंय का इकडं मोठं, इथं तुझ्या पायाला दाब जास्त पडतोय. एक पाचव्यात जो आहे करंगळी, इथं दाब जास्त पडतोय. दुसरा, तिसरा इथं पडतोय. So he has got 3 pressure points now. Though the individual is purely a normal subject, we are having this problems. So what you can just retrospectively imagine what could be the scenario with your diabetic patients and how bad their diabetic patients can go down. Okay? Sure.
Second foot also.
Yeah, we can do it for the second foot also. Yes. We'll do it for the second foot. Chalo. Rather than a असा जायचा तुला. We'll do it for the second foot. Chalo. Vara. Bas, chalo. This is what again this. Now first straight, fifth. It is not much on the first. This is the toe, fifth. Old, right? The previous one, fifth was darker. First was also dark. But here, it is not the scenario. Yeah.
Can you do it on that flat surface? Because what I feel that he is balancing.
Now we will yes. Now what we will do is we will change it. This thing has been done here just to demonstrate the. Now we'll do it on the plain surface. Yes, definitely, sir. Definitely. We'll just have a look. Please. While what they are doing is now we will go down to a Pudo stand. Continue. नहीं सरल over and चल ये समोर ये बस. Thank you. चलो good. Same weight. So it's the same. Nothing is going to change. Yes. Sure. Thank you. So this thing we can do it on the computerized scan. This is what the plate looks like. Next slide, please. Next slide, please. This is the computerized thing. We generate a computerized report. Mapping is done, and the rest of the things, depending upon the report, we calculate it. Next, please. So this is what the Pudo scan looks like of a normal first, second, and the line, the ray is straight. When we have got a flat foot, then there is more pressure in the medial portion part of the foot, and the first ray is spared, the rest of the rays comes down. If we have got a high arch foot, then the first ray has got a maximum pressure, and depending upon the pressure, the scan comes down, and depending upon that, we have to have a offloading for that, and the rest of the things comes on. Next slide, please. This is dependent Ruber. Next, please. Hey, connect. Please. So this is what we go for a vascular assessment. Please. Take a spike. We go for the pulses. What we do is, between the first and second, go down straight. This is where you get your anterior tibial, your posterior tibial. Okay? Anterior tibial, posterior tibial. The cuff has been tied over here. We, for vascular assessment, we have ABI index, that is ancobrachial index. We have systolic ankle pressure divided by systolic pressure on the biceps, and whatever the readings comes down, depending upon that reading, rest of the things comes. Next. Meanwhile, he is doing that. This is what the normal architecture is. This is what your anterior tibial, your posterior tibial. Next, please. Yes. So this is what simply, if it is 0.9 to 1.2, that is a normal ABI index. 0.9 to 0.7, mild atherosclerotic changes, or the ABI is lower, the arterial insufficiency is there. 0.7 to 0.4, moderate. And below 4, that is severe. If there is one condition where the ABI index is on the higher side, that is greater than 1.2, where the vessels are atherosclerotic, the vessels doesn't get compressed, and you get a false reading, which is on the higher side. Okay, next slide, please. This is what the same thing. Next. Yes, this is what the X-ray shows down. You can see the arrow has been pointed out to the calcified artery. Once you can have an X-ray also, you can just see the artery is calcified or not, depending on X-ray also. Next, please. This is what the reports comes down to you once you do a Doppler study. There is a normal triphasic flow, a biphasic flow, a monophasic flow. Biphasic flow, once you have a biphasic flow, there is the artery has been occluded prior or post, either or. If the monophasic flows, then the artery is occluded on the higher side and the flow is diminished below. Next, please. So this is what the Charcot foot comes down. Next, please. Yeah, this is hello. Samjo.
Ankle joint पे ना pressure दिलेलं up slow. त्यावेळेला हे चालू केलं तेव्हा काय झालं, प्रेशर आला ना तुम्हाला, नंतर ना रिलीज झालं, हवा भरली. हा ग्राफ आहे, इकडे येतो दिसतं. हा ग्राफ आहे.
See, what we have done is, there is a graph comes down. We have got a pressure area which is there. This is just a single reading. We have to take the other legs reading, then the upper arms reading, and then the ABI has been calculated, and rest of the things done. So this is what the graph comes down. It is 0.9 something he's saying. Okay, got it? Next, please. This is Charcot foot. These are the various type of Charcot foots, or the joints or the muscle, the bones which comes down into Charcot foot. Next, please. I'm just running up. This is an X-ray finding where you can, this is the first early sign when you can diagnose to have a Charcot foot. Mind it, this is mandatory, must rule that you should have a X-ray of foot that is a weight-bearing X-ray. Okay, the individual has to stand. He has to put his weight on the X-ray film, then the X-ray has to be taken. Once you have that, then this findings comes down. This is an primus angle, which is normally of 15 degree. Next, please. This is the primus angle here. Once the angle has been more than 15 degrees, that is the sign that the Charcot orthopathy or neuropathy has set in. Next slide, please. This is another X-ray where you can see the first and the second metatarsal. Next slide, please. Next, please. Here, the line which comes down. Next, the previous slide, please, of the X-ray. This is what the line which I'm saying. Next, please. Next. This is the angle of the first and second is of 16 degree. If the angle widens up more than 16 degree, that is the first and the precursor sign of having a Charcot orthopathy. The individual is in Charcot foot. The foot is in a Charcot foot starting up. Next slide, please. This is the essence of preventing diabetic peripheral neuropathy or a diabetic foot. Patient education is must. Foot care, skin care, nail care, protective footwears, protective surgeries. Next, please. I love this slide. Vigorous activity is very good for diabetes. If stamping on a chocolate cake is being made. Next, please. Yes, a wife scolding her husband. This is what you call a diabetic foot care. Is it? What do you think? No? Fine. I would be just, yes, next please. This is what the foot care checklist. Educate the footwear, educate the people properly, the patient, the attendant, the relatives, your staff, everybody. Examination, remove it. Examination, structural, vascular, neurological. 10 gram monofilament is due, must done, be done. Identified, thank you. Next, please. You can have this thing on net, so I'm not going in detail of this. These are do's and don'ts. What has to be done, what not has to be done. Next, please. Next. So structural abnormalities, we have to check for skin, evidence of infection, callus, ulcers, range of movement, Charcot orthopathy. Peripherally, we have to check for temperature, skin changes, acrobrachial index, neuropathy, 10 gram monofilament is sufficient. Next, please. Next, same. Low risk, annual checkup. High risk, 3 monthly or 6 monthly. If there is an ulcer, if there is an post-amputation, then the individual has to be referred to a multi-speciality and he has to visit the doctor monthly or once in 3 months at least. Next, please. Same, next. Yes, so this is the definition of diabetic foot ulcer. But I would differ from this definition. Anybody can tell me the definition of diabetic foot? Anybody? It is written on there. But I would differ from this. Anybody? Wild guesses? What could be? Yes. As the individual is diagnosed or you label the individual a diabetic individual, his foot become a diabetic foot. If you think in this way, the foot will be prevented. Lots of foot will be prevented. Next slide, please. 3 musketeers of diabetes. Do you really want your patients to go on with this? Next, please. So every diabetic foot says me, please save me, please save me, please save me, please save me, and please save me. Thank you for your patience listening. Thank you.
Excellent talk. May I request the chairpersons to be on the dais, please? Dr. Behre, sir, your comments?
Yes. Nice explanation. Very explanation. So, we don't have that.
What we have, a plate is there. We place your foot on the plate. There is a dynamic and a static one. Dynamic one, you walk through it. A static, just a pressure and goes out. It is basically a pressure analysis. What exactly comes in? Depending on the pressure, there are 3 or 4 colors which appears. One is red, orange, blue, green. Red is the pressure where the point where you have got a maximum pressure. Depending upon the color codes, the pressure changes and rest of the things comes down. Yes, it appears on the graph which we comes out. And you can give it to the patient. It's your documented evidence. Then the patient is asked to have a modified footwear. And after 6 months or 3 months, again the photo scan is being repeated to see whether the pressure is really getting off or not. And then the rest of the things comes. Sure.
Any more questions from the audience?
Sir,
Yeah.
the monofilament test is for pain or for touch?
Pressure, less pressure.
But see, pain we usually have been taught to have a pinprick, right? We have taught in our UGs to have a pinprick. But are you going to do this test on a diabetic patient? Pinprick is lost. Ideally, it is there. We should do it. But if you are going to prick it, and if in case the patient get infection there, then it's going to sue you like anything. So it's better not to do it.
Any more questions? Sir, any comments from you, Dr. Mantri, sir?
Sir, I have a question. Does diabetic food problem run in diabetic patient hands? Because what I have found, as a surgeon and having practiced for more than 40 years, what I have noticed is the father gets amputation, the son gets amputation. Maybe one is above knee and one is great toe amputation. But that is in that family. But other diabetic families, no problem. Is it possible?
So what happens exactly is once the genes transfers, then the rest of the things get transferred.
So
you are
whether it is a genetically transmitted problem.
You can't
in a diabetic, for a diabetic food, the same goes into family. Kidney goes same into the family. Cardiac problems, they go in that family.
To some extent, yes, but you can't label it completely. It depends on the patient's, what we say it as social behavior. Social behavior also. If the father was a smoker, a chronic smoker, the son is not a smoker, the atherosclerotic changes doesn't happen. He would spare, or he would be just having a toe amputation, which you have said. Then it would have a toe amputation, not a below knee.
One gets amputation here, one gets amputation there. It goes into the family. That's why I asked. What is your opinion?
It sometimes goes, because I have a patient. One patient is diabetic. His brother is diabetic. Both went down to amputation. But it runs. I have not seen into the literature. I have to look into the literature and get back to you.
Yes, sir. So, a few concluding remarks. Yeah, diabetic foot is the result of peripheral neuropathy, peripheral arterial disease with trauma and pressure. It has a wide range of presentation ranging from break-in skin, superficial cellulitis to chronic osteomyelitis. Detailed and thorough examination of foot is the key in management of diabetic foot. The clinical examination comprises of 4 major components, that is musculoskeletal, vascular, neurological, and dermatological. All patients of diabetes must have their teeth evaluation every year, at least a year. And if there is any deformity, any problem, as you rightly said, every 3 to 4 months. Systematic examination, risk assessment, patient education, and timely referral are the important aspects of the management of diabetic foot. Thank you, sir.
I would like to add one point in it, which is missed across the globe, or the patients or the preaching sometimes misses it. It is called as a psychiatrist has to be involved in a management of diabetic foot. Because the individual is in such a depressive phase, we have to have a psychiatric help to come it across. So psychiatrist is must in a diabetic foot care team. Sir. Yes.
What are the ways whether exercise can create all these changes?
See, the changes which occurs in diabetic foot depends upon the footwear which you are using, the amount and the exercise which you are doing, the pattern of your day-to-day lifestyle, and depends upon the weight, what exactly the weight and how healthy he is. Depending upon that, the pressure changes and the things happens. If you have a long-standing diabetes with the sugars which are on the higher side for longer duration, then the neuropathy is being affected a lot. Once the neuropathy sets in, the changes sets in. We can't delay a neuropathy. We can't repair the neuropathy. We just have to we give it on a halt or into a controlled phase. We can't reverse it unless and until there is an entrapment of the neuropathy which is there. That's a different scenario altogether.
With the exercise, yes, this can be delayed.
Which changes? The foot changes you are saying? See, there is a dictum. Once you have a peripheral neuropathy, once you see that it has the patient is having a peripheral neuropathy, he is prevented from jogging. He is preventing from doing vigorous exercises. He would be doing cycling, walk in a swimming pool, or plain routine walking. He won't be allowed to do a vigorous exercises. That's a dictum. So you can't ask the individual to go for a vigorous exercise. Once his fit is at a high risk, or there is a peripheral neuropathy which is sets in, the sensations are down. You literally can't hide it. There was one incident happened in US, I think so, 1.5 years or 2 years back, where the individual sued the doctor because the doctor had advised him to go for a vigorous exercise. He had a peripheral neuropathy. He went down into a charcot foot, and this thing happens. So it has to be a non-vigorous exercise.
I understand there are many questions, but we can discuss it later. We are running short of time. Thank you, Dr. Mantri and Dr. Behere for chairing the session. May I request Dr. Meenakshi Deshpande to come onto the dais to felicitate the chairmen for this session.
Thank you, Dr. Behere sir and Dr. Mantri sir, for chairing this session. Now I request our two stalwarts from IMA Pune, Dr. Sanjay Patil sir and Dr. Amrish Shahade sir. They have also come in uniform. Come, sir, both of you. I think both of them, they don't require any introduction, but to just to I will tell the yes. Dr. Amrish Shahade sir is a renowned general surgeon, and he is practicing in Parvati Paitha at Shahade Hospital near Mitrabandal Chowk, and he's our IMA past president, as well as he's an active IMA member who is in our managing committee, as well as Madam, मी जरा सांगते सरांचं इंट्रोडक्शन करते डॉक्टर संजय पाटील सरांचं ऐका नाही I know it, but I have to tell to others 250 people, they are watching this online. Okay.
From abroad as well.
Yeah, from abroad as well, sir. So Dr. Sanjay Patil, sir, he is the executive trustee of IMA Pune. He is a past president of IMA Pune, and he is our guide and philosopher and everything for IMA. So over to Dr. Gitanjali Sharma.
शाळे सरांची एक छोटी इंट्रोडक्शन अजून आहे. Yeah, he is the strong support and pillar behind our today's ma'am, Aarti Shahade madam.
Can I take a second?
Yes, yes, ma'am.
His question was very typical questions, and probably I think it was difficult to mismatch. Once the patient is diagnosed as diabetes, to maintain the elasticity and to increase the vascularity, you have to do exercises. Neuropathy is directly management of your diabetes. So strict management of diabetes will postpone the neuropathy, and elasticity of the joints is very essential to postpone the diabetic foot problems. So when you diagnose a patient of diabetes, this comes in play. Once the neuropathy is established, once the diabetic foot comes to me, it's the other end of the spectrum. It's already established. So very difficult to comment on neuropathy and vasculopathy. Yeah.
Thank you, sir. Just now we had an excellent live demonstration of examination of foot neuropathy checking. So now we are going to have again a talk and live demonstration of how to do dressing of the wounds. And today's speaker is Dr. Vinaya S. She is a pediatric in Bhagwan Mahavir Jain Hospital in Bangalore, and she is practicing for more than 23 years. She's done her fellowship in pediatrics from King's College, London. And she is an executive committee member of Diabetic Foot Society of India, in association with whom we are doing today's CME and workshop. So over to you, Dr. Vinaya ma'am.
No, she's there. Let's start. Lecturer Good morning, everybody. First of all, thank you, IMA, for inviting me here for a lecture, and thank you to Dr. Aarti Shahade. I work as a podiatrist in Bhagwan Mahavir Jain Hospital, Bangalore. I've been there for the last 23 years. Jain Hospital, Bangalore is one of the first foot clinics in India. Foot clinic concept is very new in India, and last 20 years, it's come a long way. When we started the foot clinic, the first question from the surgeons and orthopedic surgeons were, is the foot clinic separately needed? Whether the podiatric care is needed in India, because they were doing most of it. But even before the surgical stage, we need a podiatry examination and podiatry procedures to protect the patients from amputation prevention. And amputation prevention took a very major role in setting up the foot clinics in India. And now today we have 23 foot clinics in Karnataka set by Jain Institute of Vascular Sciences. What do we do? Before we moved on to the wound care center, it was a pure foot clinic where we did the education, evaluation, foot care, footwear prescriptions, and consultation for the foot problems, and then to wound care and the dressings. Because we were attending to the patients who were symptomatic and non-symptomatic both, who were referred from the physicians, where we examined the patient, educated them, what symptoms if they have, they need to come to the foot clinics and report to us. And even if they have a very small problem, they came and examined their feet in the foot clinic. Then we moved on to the patient where they had a small wounds, bigger wounds. They came to us and told us that we have a wound. Then we started the wound care center and no on. The first thing what we did was complete neurological evaluation, vascular evaluation, as you learned in the previous lecture. Dr. Amit Nagate has explained to you very well. And the callus is the most neglected part
with the patient. If they have a hard skin under the feet, they think that because they walk barefoot at home and barefoot outside, the callus has formed. They keep walking on the callus and the callus becomes bigger. And when it breaks down, it becomes an ulcer. Under the callus, there can be a big ulcer which needs to be surgically removed. But we just pair it externally. We don't go deep into that. Only if there is an ulcer, then we start treating that. So the podiatry instruments are adequate to remove the callus from the feet. And you can see these nails, these are the fungal nails, and most of the diabetic patients over years, 8-10 years, they develop fungal nails, and just the application of the creams and cutting of the nails will not solve this problem. Probably they give systemic antifungals and they need to take the fungal nail treatments regularly, and we can find the fungal infections in between the toes, and that's what leads to the ulcers in between the toes. Most of the time, the local issues are the peripheral neuropathy and deformity and previous ulcer formation of the patient, and prolonged time of pressure in the same points can lead to the ulcers, and also limited joint mobility. So the foot wounds are divided into neuropathic ulcers, neuroischemic ulcer, and ischemic ulcer. And all these three needs to be addressed individually. So the neuropathic ulcers, patient may not have sensation at all in the feet, and patient can walk over the neuropathic ulcer for months and months. Unless he himself notices or someone else notices, they may not be able to make out they have an ulcer at all. So they have a bounding good pulses and distended dorsal veins. They have a high arch and clawed toes, as you have seen the pictures in the previous lectures, and loss of protective sensation, and he will not perceive any trauma or infection unless it is noticed. And neuroischemic feet, they may have a very poorly felt pedal pulses. Maybe one of the pulses are absent, and foot is cold and pink, and may be painful, may not be painful, depends upon the neuropathy grade, whether it is moderate or mild, and ulcers on margins. And diabetic foot infections are the great destroyer of the diabetic foot, and that spreads very, very quickly. When the patient comes into the foot clinic, we see with the great toe ulcer, we tell them to get admitted, take IV antibiotics, and come the next day after starting the oral antibiotics. We ask them to get admitted if it gets severe. We ask them if the redness extends to the knee, they need to come back to us. But if they ignore it and come after 2-3 days, it would have extended as cellulitis below knee. So it can spread very, very rapidly. And unless we give a good education to the patient when to come back to us, we cannot prevent them having severe infections. And early detection and the rapid treatment is very essential, because from the outside, it looks very small, but the infection may be deeply into the foot. So mechanical control of the patient with foot infections are very important. Offloading footwear for the foot, offloading the particular area of the foot is very, very important with a special footwear. And they can be on bed rest for some time or use crutches or a wheelchair during the infection period, and foot needs to be elevated. The metabolic controls are hyperglycemia control with the diet, OHAs and insulins, hypertension control, hyperlipidemia control, and smoking cessation. We see even with after the amputation, patients keep continuing to smoke, and when they come to the clinic, they say that we have not been smoking, but the smoking can cause a lot more damage to the feet than they think. So it's very important to do the lifestyle modification for them. We run a lifestyle modification clinic inside our foot clinic, and we help them to stop smoking. We give nicotine chewing gums, and we do the counseling, and we will help them come out of smoking, because they are the chronic smokers. They have been smoking for 20-30 years. So the dressing, when the patient walks in, what dressing to put? That's the question. And probably we give a saline wash and we give a diluted betadine wash and just cover the dressing with some kind of an ointment. But just one particular dressing is not right for all the patients. Different stages of healing, we need to apply different kind of dressings. The first thing is to protect the wound from bacteria and foreign material, and it should absorb the exudates, and we have to prevent the heat and fluid loss, and compression is required for the foot, and we have to create a warm and moist occluded environment, and it should be clean dressing. They should not want barefoot after we put the dressing. So there are non-adherent fabric dressings, gauze and foams, occlusive dressings. There are different kinds of creams, ointments, and solutions, which is antibacterial and enzymatic and others. I have few dressings here, but we have many more. I'll show few to you. So regularly what we use for the contact is the So on a dressing trolley, usually what we have is a normal saline and regular Metrogyl ointment and the betadine ointment on the trolley. We use betadine, but not a strong betadine. It needs to be diluted at least 1:10, and only then use it for washing the foot. Even when the better to avoid the powders. We get iodine powders, but we have to avoid that. And as much as possible to keep the wound moist, we have to use the ointments only. But apart from that, we can use the different kind of dressing, and dressings with the cushioning is better. There are foam dressings which are available in a different company, and foam gives some kind of a cushioning to the feet. Okay. Yeah, the foam dressings are there. Yes. Yeah, this is the foam. Foam dressings can be used. Foam gives a cushioning, and it has got an absorption capacity so that it can be absorbed. And there are contact dressing. So this is a Urgostar dressing. It not only contacts the wound, it also absorbs the necrotizing tissue, and it helps in healing. And these are the new dressings which are come in India. And Urgostar border is another dressing which adheres to the wound, and it also has got a very good healing and absorbing necrotizing tissue capacity. And followed by that, we can use the silver dressings which are available. Silver ions helps in healing. The main thing in the dressing is what is available in your foot center to use that, and it also depends upon the economical condition of the patient. Suppose we need to prescribe the very new dressing which is available in the city for that patient may not afford to wear that. So if you don't have these newer things in your setup, just give a good saline wash and remove the callus surrounding the ulcer. And if there is a very good blood circulation, just keep the wound moist and put a dry dressing. Keep a gauze pad and cover the dressing. They can do the dressing every alternate days or twice a week. And if one of the patient relative can learn how to do the dressing, we tell the patient relative to give the saline wash and do the dressings at home. But there are some wounds which are infected, which has got a lot of necrotizing tissue. Then they need a debridement, and we need to put the special dressings for the healing. So when the healing is required along with the dressing, they need to come back. So we use different kind of dressings to them. We also do things like surgical debridements, ultrasonic debridements, and then do the dressings for them. After one stage, we need to change the dressing. So patient cannot buy a big dressing and keep on applying the same thing at home. And they think even if I go to the hospital, doctor is going to do the same thing. So we have to tell the patient when to come back when they are doing the home dressing, and the danger signs to watch whether there is any redness surrounding the wound, if there is any color change in the wound, or if there is any other danger signs like chills and fevers, they need to come back. Sometimes the wrong dressings cause a lot of problems to the foot, like infection. So when we are using the special dressings, we need to be very careful. So foam dressings are polyurethane ones. They are good absorbent, non-adherent, and expand to the conform to the wounds with the unusual configuration. They can be easily removed also. So there are many available in the market. Whichever is available in your city, those can be used. But hydrocolloids helps in healing very well because it completely occludes the wound, promotes the epithelialization and the granulations, and maintains the moisture without gaseous exchange across them. And blood vessels develop and granulation tissue forms very quickly because of high CO2 pressure. There are hydrogels available. These are 80% water. So the gels and sheets are available. And this is very good because it keeps the moistures on the wound. And microbiological control is very infection. Whenever they have an infection, we take a culture swab, send it to the lab, and according to the culture report and what medications are sensitive to that, we can give those oral antibiotics so that the infection is controlled. And it is very hard to diagnose in diabetic foot because there will be multiple microorganisms found in the diabetic foot. So sometimes we need to watch on the culture. Maybe we need to do the second culture and third culture even after the antibiotic dosage. So the usual signs of infection are the redness, warmth, swelling, and sometimes pain in the feet, but we may not see the pain in the neuropathic feet. So nothing is available. The normal saline gauze can be used for cleaning the dressing, and change of the dressing should be done regularly with the wound inspection. Now the wound inspection has become much easier because the patient himself, they can take the photographs and send it to us to the clinic. There are biological occlusive dressings also like homographs, xenografts, and amnion dressings. These are genetically made, and graft transplants are from the species like pigskin and derived from the human placentas. And these work very well in healing. We can see the wound closing very fast when we use these grafts. In general, the dressing should be soothing to apply, it should be occlusive, and it should deliver the antibiotic and limit the scar formation for the feet, and it should at least have an action for 12 hours. Most of the wounds, it's very good to change the dressing every day, but some of the dressings, the action of the dressing remains for 48 to 72 hours, so we can hold on and change alternate days or once in 3 days. So the creams and ointments and solutions also work very well on the patient's foot, but we should be very careful what to use on the patient's feet. So the silver dressings are the newer things, which is very good, which is faster in healing the wounds because silver impregnated dressings are occlusive and promotes a moist healing environment. And it has the antibacterial activity, which can persist for 3 days. So we can change the dressing only twice a week. Mupirocin is one of the old, but still the best ointment, which is used in the foot clinic. And most of the time, mupirocin ointment with the combination of the antibiotics works very well for the simple wounds or the newer wounds which has formed. I have also seen this whenever there is a summer, patient walks and gets the blisters, and when you de-roof the blisters, the silver dressings and followed by that mupirocin works very well. And instead of taking 8 weeks to heal, within 3 to 4 weeks, we can heal the wound. Calcium alginates should be used with a lot of care because it absorbs the exudate up to 20 times its weight, it reduces the prothrombin formation, and it's a soft and supple, and it takes the shape of the wound and all that. But some of the patient can have skin allergic reactions surrounding the wound with calcium alginate. So we use it with lot of care. And this is the newer dressing which has come, Orgo Clean AG. We have done a small study using it for 4 weeks on a patient. The healing rate compared to the similar wound is faster with this. It not only promotes the wound healing faster, we can keep this dressing more than 48 hours to 72 hours. So how do we see how much depth the wound has and how much width the wound has, and what kind of microorganism is present in the wound and which area of the wound? This is a new camera which is recently manufactured in India. It is made in Chennai. It is called as Illuminate. We bought this camera just 3 weeks back, but we were looking at this camera from 2 months. It is one of its kind in the world, which is recently given to our Prime Minister Modi. They have presented this camera. We just bought the camera. These are the pictures which are taken. This gives us width and depth of the wound. It also shows us the microorganisms found on the wound. The green and the red marks you can see, that shows the gram positive and gram negative pictures of the wound. And according to that, we can treat, and those areas we can give good wash on the wound and treat the wound. These are the pictures which are taken in our clinic. And it also gives the instant report to show that how much wound depth and width it has and what microorganism is there. It also catches Pseudomonas. You can see the fluorescent color on the wound. That is the biofilm which is found on this wound. And according to that, we can treat with ultrasonic debridement, where we can remove the biofilm. And there are few newer dressings which can be used for the biofilm eradication. So wet to dry debridement is recommended. We have to clean the wound and pack it with the saline moisturized gauze. And only thing is, with the simple dressing, the granulation and epithelium also can be removed when we are removing it. So better to make it wet with the normal saline and then remove the dressing. So these are the newer dressings which I showed you some time back. Not all the dressings I was able to show, but these newer dressings, when it is right for that particular patient, we can use. But there are things like hydrogen peroxide, which should not be used on the patient's foot directly because it can destroy the soft tissue surrounding that. The prozole is a dressing where it has got a hole in the center. So when we want to offload the ulcer, we can keep the prozole dressing on the patient's feet. Center of the dressing, there is a hole, and that ulcer can be offloaded and the dressing can be done. This offloading dressing can be left on the feet for 1 week, and we need to change the dressing once in a week only. I think these are available in Dyna company, and usually we stock this and use it for the patient because the healing is faster and we need to change it only once in a week. And the FibroHeal is a dressing. It's a silk protein derived, which can be applied on the wound very easily. And this powder remains on the wound for 4 days and helps in healing. We need to change the dressing only the 5th day. So it makes the number of dressings less and the healing rate faster. The ultimate goal is to prevent amputation and to protect the foot from further complications. And periodic offloading and continuity in the care can heal the ulcer. But patients should always remember, once they have an ulcer, within 1 year or 3 years, they may get the wound back on their feet. So they need to use the offloading footwears or diabetic footwears inside the house and outside the house. Whenever we give a footwear to the patient, they say that we have been using the footwear, but for 12 hours, they may walk inside the house. 1 or 2 hours only for walking, they may be using that shoes. So using the footwear inside the house can prevent reoccurring of the patient. This is the ultrasonic debridement machine. It's called from Soaring. Previously, there are two companies which were there in India. Previously, we were using the different machine, but now the spare parts are not given. So newly we have got this Soaring machine. It debrides all the necrotizing tissue very well within 20 minutes, and the healing gets faster. Even when we want to take the patient for plastic surgery, before that we do the ultrasonic debridement. So the wound is clean, the borders are clean, easier to go for a skin grafting. Thank you. Any questions, sir?
Thank you, ma'am. Any questions from Chairman, sir? Any comments from you?
The essential thing of treating any diabetic is getting a Doppler and getting an X-ray to know whether there is osteomyelitis or not. Usually the neuropathic wounds are dry, so it can be managed at nurses or lower level. Any wound that has high discharge should be given to a specialist, or it should be under supervision. There are there is some rich creams are available now. They can be used for promoting the wound healing. And latest, if there is the wound discharge is quite copious and large, you can apply a vacuum dressing, which probably is I say boon in disguise for all diabetic wound, which reduces the granulation tissue which we used to get at the end of 2 or 3 weeks. We get it at the end of 1 week, and the patient is ready for skin grafting, and a plastic surgeon can handle the wound better. And also contact cast is very important for relieving the pressure, and serous slab immobilization is also important for wound healing. Thank you.
Thank you very much, sir. We can use the total contact cast. It's the golden method. 90% offloading is given by the total contact cast, as said. Thank you very much, sir. We also used air cast. If the patient compliance is not good, then we can use the instead of total contact cast, we can use the air shoes. Air casts work very well. They can remove at the end of the day while sleeping and they're taking bath, and it can be reapplied on the food. And back therapy, yes, back therapy works very well. We give it to most of our affordable patients so that most of the secretions come out to the dressing, and the healing rate is faster. And KCA back dressing is the regular ones what we use, but many have come now. Here the patient can carry the back dressing to the house, and they can come back the next day. And the home dressings also are available by the KCI, so they do the back dressings at home. Usually post-op also 4 to 5 back dressings are done, and followed by that they can go for the regular dressings. And many negative pressure wound dressings have come now.
The important thing in diabetic food is you cannot just take a swab from first culture sensitivity.
Yes, sir.
You have to send a deeper tissue. You have to excise it and then send for culture sensitivity. That is the proper way of getting a good report from microbiology. You have to send tissue sample for culture sensitivity and not just a swab.
Thank you very much.
Interesting talk on this good care. I think we should have one center in Pune city to lead such spaces, which is lacking in Pune city. This is the first message we have received, and we were quick comment about the amniotic membrane used in such
Yes. The amniotic membrane we use on the placenta-derived amniotic dressings are available readily. And from Mumbai, we used to get the placenta-derived dressings not from a company, from the research institute. And we used to apply it on the patient field, but we got it for a very short time because it was for a research, but it worked very, very wonderfully. And I have seen an ointment, Placentrex, yes, which is used for years. It heals wonderfully. Because now the debriding agents also have come like debridase and all that. I have seen it works like Placentrex only. When we use debridase on the patient's feet, it beautifully starts healing. The borders start closing very, very quickly, and it heals very well. I have seen very less people using Placentrex, but whenever it comes to the patient's choice and patient says it is not expensive and I want to use only this, then we use Placifix on the patient and it did work very well. Within 3-4 weeks, the wound heals.
The skin replacements are available in the market.
Yes, sir.
Dr. Kulkarni was been knowing it, but they are very, very expensive. Small 2-inch into 2-inch will cost you about 40,000 rupees.
Yeah, the skin, this one of the trial in 1996-97, it was a dermagraft trial, which was done in US and one of the centers for King's College. The podiatrist Ali Foster and Mike Edmund was doing it in UK and I was part of the center. The dermagraft was supposed to be kept at minus 17 degrees and it had to be taken and put on the patient's feet, and I was thinking like it was impossible to get it to India, but within 20-25 years, now it has come into India and there is no need of keeping it in minus 17, minus 7, minus 5 degrees. We can just get it and we can place it on the patient's home. It can be just brought from the pharmacy and put on the patient's home. But still, these are very, very expensive. And more dressings come into India, I think it gets cheaper and we can use it for the patients. I have seen poor patients and the richer patients also, but when it comes to a wound and dressing, rich and poor are the same. Because when the wound goes for 5 months to 1 year, even the rich patient, middle class patient, they keep on paying for the dressings, keep on paying for the debridements, and they will not be able to do the regular work and go to work, and they spend a lot on the wound. So the healing time of the wound should be reduced. With what we can reduce the healing time, that needs to be done. So this has to be taught before we treat, because we cannot keep on doing the trial and extending their healing period. So when the patient comes, we need to think we are going to heal this patient within 3 months, within 8 weeks, within 4 months, and we have to see that they don't have any other control. The main thing is the glycemic control. We completely put our concentration on the feet, forget about the glycemic control. Maybe they are sitting at home, they have a foot wound, and their sugars are 300, 500, 600, and they don't care about it. So glycemic control is tight, then the wound healing is faster. Thank you.
Thank you, madam. That was an excellent talk. Very well explained. We also have to educate the patients. I have seen a few patients using, I'm just naming a medicine, but I don't want to say anything against. There is a cream called crack cream, and many patients use this crack cream and they develop diabetic foot, gangrene, and sometimes many other complications. So awareness of patients is also very important. Yeah, I didn't want to say that because there are so many like this. So awareness and education of patients is also very important and very well explained, madam. Thank you. Madam has come all the way from Bangalore today. Thank you. And yes, he has come all the way from Bangalore. Thank you, madam. Now we move to our next speaker. He is Dr. Shrikant Goyal from Borivali. He is a general and diabetic foot surgeon. He is a diabetologist and pediatrist. And he's waiting for a long time now. So let's go to his talk. He's going to speak on diabetic foot infections. So over to you, doctor. Online. He's online. Yeah, he's online. He's over there. Dr. Goyal, sir, you can share your screen and can start.
Thank you very much for giving me the opportunity. Can you see my slides? Hello. Can you see my slides?
Yes, we can.
Good afternoon, everybody. I am going to talk about the diabetic foot infection and its management. We all know that India is home to 800 million diabetic patients. Out of this, 15% of diabetics will develop foot ulcer in their lifetime. 15% of the foot ulcers will develop osteomyelitis, and 15% foot ulcers will lead to amputation. Out of this amputation, 50% are at transtibial or transfemoral level, means at higher levels. 50% patient will develop amputation, second amputation in 5 years with of their first amputation, and 50% patients die within 5 years of their first amputation. So mortality is quite high. And for all this, the ulcer is the pivotal event. So an 85% amputation in diabetic patient result from non-healing ulcers. So prevention of ulcer, if the ulcer is there, healing of the ulcers, prevention of recurrence is also very much important in the management of diabetic foot. Coming to the pathogenesis of diabetic foot, I think this has been talked earlier, so I don't want to give a lot of time to this. Is a neuropathy, vasculopathy, infection and biofilm formation, restricted joint mobility, diabetic osteoarthropathy, immune dysfunction. So prolonged hyperglycemia contribute to all of our factors through different mechanisms. So keeping the blood sugar in tight control is important. Now coming to the neuropathy, there is, we all know, there is sensory neuropathy, motor neuropathy, autonomic neuropathy. You can see the example of sensory neuropathy. This gentleman has burned his foot while walking on the hot summer in the hot tiles. Coming to the diabetic angiopathy. In diabetic, there is a macro and microangiopathy. Macroangiopathy, you all know about the atherosclerotic disease of the large arteries. Microangiopathy is unique to the diabetic patients. There is an increased thickness of the basement membrane, endothelial proliferation, and medial wall calcification, making the vessels stiff, because of which there is a decreased local blood supply, poor penetration of the antibiotics, and poor wound healing. A dysvascular foot is a foot without having any palpable pedal pulse or a documented ABI of 0.9 or 1.3. This ABI measurement you might have seen in the earlier presentations. A neuroischemic foot is a foot which is a full, hairless, with atrophy of the subclavian tissue and the muscles. So coming to the diabetic foot infections are among the most frequent and serious consequences of diabetes. They are the most frequent causes of the hospitalization, responsible for more hospital day stays than any other complications of diabetes. Infected foot is the greatest cause of tissue necrosis and tissue loss. Diabetic foot infections accounts for 80%, 60% of the non-traumatic lower limb extremities. And 85% of amputations, as I told you, is preceded by the foot ulcers. Diabetic foot infections with PVD have a 90% higher risk of amputation than without PVD, peripheral vascular disease. Infected foot, isn't it possible that so short a time can alter the condition of a man, said by William Shakespeare. This gentleman had a small diabetic foot ulcer on the plantar aspect of the foot, and he was carrying it for a long time because there was no pain. It was an insensate foot. Generally, we in India, we say more the pain, more important, more serious is the problem. जो ज्यादा चिल्लाता है उसकी तरफ ज्यादा ध्यान दिया जाता है, जो चिल्लाता नहीं उसका तो कोई देखता ही नहीं. So he neglected this wound, and later on it developed into a necrotizing fasciitis, threatening his limb and life. So 85% of major amputations in diabetic patients begin with a clean ulcer. So healing of the ulcer is again important factor. Coming to the Wagner's classification, there are so many classifications are there. It is the most widely quoted classification. It grades the foot depending upon the severity. Intact skin in a normal patient, diabetic patient with a normal skin. Superficial ulceration, the deep ulcer deep to a tendon or bone or ligament. Then there is osteomyelitis, localized gangrene, and gangrene of the entire foot. That means there is an unsalvageable foot. These are the various stages of the Wagner's classification. So if we come to the spectrum of the clinical disease, there is a localized disease, spreading infection, severe infection. Localized infection in a ulcer with the surrounding skin, the local signs which suggest the infection are pain, changes in the base of ulcer from pink to yellow or gray, increased friability of granulation tissue, increased amount of exudate becoming purulent, unpleasant smell. These are suggestive of a local infection. There is another classification like Wi-Fi classification which says that there is an ulcer, localized ulcer with the erythema less than 2 centimeter. It is a localized infection. Erythema more than 2 centimeter. There is a spreading infection. and infection spreading to the deep down tissue. There is a deep infection. Spreading infected ulcer with a diffuse spreading erythema, edema, lymphanginitis. The portal of entry may be corn, callus, blister, fissure, or any other skin break. So important of treating these calluses, corns are very important. This patient require watch or hospital admission, debridement, IV antibiotics, and wound care. Severe infections. Extensive deep tissue infections or infected ulcer with a blue, purple, or blackish discoloration. There is a generalized sloughing of the ulcer and surrounding subcutaneous tissue. In the late infection, present with the swelling, sloughing of the blister formation, suggestive of necrotizing fasciitis, necrosis secondary to septic vasculitis. There can be a systemic signs like tachycardia, hypotension, high fever, reduced body temperature. I am saying there can be systemic signs. Treatment is hospital admission, IV antibiotics, debridement or amputation, metabolic control, insulin treatment, correction of electrolytes, etc. Key points. When a patient is presenting to you for the first time, it is with a superficial ulcer, usually it is non-infected. When there is an infection, most of the time the infection is staphylococcal gram-positive infection. When this patient is coming from other hospital or a doctor, after receiving some treatment or antibiotics, there may be both a gram-positive or gram-negative organisms. When there is a ischemia is also present, then assume that there is an anaerobic infection also in addition to gram-positive or gram-negative organisms. Pain may be the first symptom of the infection. In the superficial ulcer or deep ulcer, there is a pain suggests the infection. If ulcer is not healing for a long time, more than 2 weeks, suspect the osteomyelitis and direct your investigations towards that. There may be no fever, no pain in the spreading infection. So that's why you have to be very careful in diabetic foot infection. Systemic signs and symptoms are notoriously absent in many severe diabetic foot infection because of immune dysfunction. When the fever is present, it is usually indicate severe infection with involvement of the deep tissue necrosis. So whenever the patient of diabetic foot infection come and there is a fever, suspect the deep tissue infection. Diabetic patient require the prolonged course of antibiotics. WBC may not be raised in diabetic patient. So you must go for a CBC, ESR, CRP, and that may suggest you the severity of infection or response to the treatment. CRP is a better marker. More than 200 CRP suggests the deep infection. Serum procalcitonin levels also promising marker for the severe bacterial infection. Don't attempt even nail cutting or debridement or plan surgery before evaluating for a vascular status of the limb. You or your patient may land up into trouble. I will show you one case later on. Angioplasty can be a valuable adjuvant to the treatment of infection in ischemic foot. However, if the ischemia is present, ischemic patient present with extensive wet necrosis or sepsis, it is emergency and investigate for the circulation. But if the necrosis or infection is limited to 1 or 2 toes, start with the IV antibiotics, convert the wet gangrene to dry gangrene, do revascularization, then go for amputation. You may save the level of amputation. Coming to the microbiology. Generally, diabetic foot infections are polymicrobial. They contain aerobes, anaerobes. Then again, there can be a fungal infection. Gram-positive and gram-negative bacteria and fungal infections is also present in the near about 10 to 28% of diabetic foot infections. So our antibiotic treatment should be cover all the spectrum of this bacterial infections. Infection into ulcer can lead to cellulitis, abscess formation, osteomyelitis, necrotizing fasciitis, gangrene, amputation, even life-threatening complications also. These are the various bacteria which are isolated from the diabetic ulcers. There can be gram-positive, Staphylococcus aureus, MRS, methyl-resistant Staphylococcus aureus, gram-negative anaerobes, bacteroids like that. Diabetic patients are immunosuppressed. The neuropathy and ischemia reduces local resistance to invading bacteria. So Louis Pasteur has just said the germ is nothing, it is the terrain in which it is growing. So repeated debridement, and making the wound bed preparation is very much important in the management of diabetic foot ulcers. Biofilms. Biofilms is a diverse microbial colony attached to the surface of one or another and embedded in a thick, slimy barrier of sugars like glycocalyx proteins and water produced by themselves. The barrier protects the microorganism from external threats like host defenses, antibiotic, microbial therapy like topical or systemic antibiotics. Why these biofilms are so difficult to manage? Because they suggest the chronic long-term infections, they are resistance to host defenses such as phagocytosis and killing. It is difficult to diagnose, frequently recalcitrant to antibiotic treatment, and difficult to treat. Only cure may be removal. So this is the patient having the small ulcer but having the biofilm formation. Whenever this patient comes after 2 to 3 days or 4 days to my clinic, he has a biofilm formation. So what you have to do is you have to remove the biofilm and make the ulcer thin. You can see the difference between the when the presentation is there and after the removal of the biofilm. So healthy granulation tissue can be seen, but again the patient when comes again after some time, after 7 days to 10 days, again he can have a biofilm formation. So what I devise is I ask the patient to use the toothbrush. So buy the toothbrush from the shop, a simple toothbrush costing 20 or 30 rupees. Sterilize it in hot water, and every time they do the dressing, just clean it with the bristle of the toothbrush. So that can remove the biofilm. Otherwise, if the patient is coming after the 15 days or 20 days to you and doing dressing at home, you suspect there is a chronic infection, and this chronic infection is not removed, it can lead into that can penetrate down and involve the bone. So importance of biofilm removal is very much in the management of diabetic foot ulcers. So whereas antibiotics treating, we can have the organisms, and accordingly you can have oral antibiotics or IV antibiotics. Osteomyelitis in diabetic foot. Osteomyelitis should be suspected when the sterile probe penetrates to the bone. 20% of the infected ulcer will extend to the bone, causing osteomyelitis. An emergence of drug-resistant bacteria and biofilm formation along with the vascular compromise makes difficult for antibiotics to reach to in a sufficient concentration to the target tissue. In the chronic osteomyelitis of toe has a swollen red sausage-like appearance. Lab investigations like CBC, ESR, CRP may be more sensitive but of the questionable quality or specificity. Microbial evaluation by bone biopsy is considered as a gold standard. Imaging X-rays of the foot are most effective but have a low sensitivity in early days of osteomyelitis. X-ray may take 10 to 14 days to show the signs of osteomyelitis. So if you want to catch the osteomyelitis early, you can have a MRI or CT scan. They can catch the osteomyelitis as early as in 3 to 4 days. So MRIs are the basic, are the important investigations as compared to the in the osteomyelitis as compared to the X-rays. But the patient coming later on 10 to 14 days of the ulcer and you are suspecting osteomyelitis, you can go for the X-rays. Treatment is always debatable whether to do the medical treatment of the osteomyelitis or surgical treatment. You require a long antibiotics, long-standing antibiotic for 3 weeks to 3 months, or surgical debridement. We surgeons believe in the surgical intervention of the to prevent the spread of infection. And latest international IWDC, International Working Group on Diabetes, promote the surgical removal of the infected bone as a primary mode of treatment than the antibiotics. These are the various laboratory investigations you must do for the any wound, any ulcer of infected ulcers. First culture and sensitivity should be taken from the when you debride from the base of the ulcer. You should take the swab and or tissue and send it for the first culture and sensitivity. X-ray, ECG, 2D echo also important because when there is a disease into the leg, there can be disease into the heart also. So sometimes when you are giving anesthesia and these things, some patient may land up into other problem. So patient will blame you that he has come for the foot treatment and he has landed up into heart attack. So taking care of this is important. X-ray investigations are very important. In this X-ray, you can see the calcification of the anterior tibial artery. Posterior tibial artery is also there, digital arteries. You can see there can be gas also there. You can find out the foreign bodies, metals, and pathological fractures with the help of the X-rays. CT scan can show the findings of osteomyelitis earlier than radiographs, but are less sensitive than MRI for the soft tissue and osseous infection. MRI is primary for assessment of bone and soft tissue infections in diabetic foot. So, for the osteomyelitis, you can go for an MRI. MRI also picks up the osteomer changes, and it can also show us the ulcer and the sinus tract. In the case of cellulitis or necrotizing fasciitis, MRI may say it is a cellulitis, but your clinical judgment should be there to differentiate between the cellulitis and necrotizing fasciitis, because necrotizing fasciitis is a very deadly infection and spreads rapidly. And MRI only may say that it is a cellulitis. So using the clinical judgment is very much important. Then there is a vascular listing. You can go for arterial Doppler to know the PVD, blood flow, identify the stenosis, occlusion of the vessels. Angiography indicated in the diabetic patient with non-healing ulcers or osteomyelitis who require mapping of the vascular disease prior to the endovascular surgical treatment. MR angiography and CT angiography benefit of providing the detailed anatomic mapping, but digital angiography is the standard. Not only that, use the diagnosis, but it can be used in further therapeutic procedures at the same time only, like angioplasty, atherosclerotic atherectomy, stenting, and thrombolysis. Coming to the case discussions. For the management, you can divide the ulcers into different site locations. I will take the few examples. Coming to the dorsal ulcers are usually from the friction injuries of the footwears. Invariably, they are secondary infective etiology. The infection spread rapidly into the along the tissue, loose tissues of the dorsal aspect. Good debridement and skin grafting can have your foot back. This patient started with a ulcer on the small toe, then develop rapidly into the localized necrosis of the tissue. We did the debridement, put a VAC dressing. After VAC and skin grafting was done. This is the picture after 1 month, and the patient later come after 3 to 4 years, and you can see the normal licking foot. So you can provide the foot provided you catch the infection early. Now this is a 72 years male with the 20 years of diabetes undergone, say which his ejection factor was 20%. Is managed with debridement, irrigation VAC, and sciatic femoregional block. This patient has come to me from the Surat. There was a localized small infection. Every time that surgeon was doing debridement, every time the wound was spreading. And when he came to me, the infection was spread up to not only from the foot to the leg, it has also involved the bone. So here it shows the importance of good debridement. You have to debride, surgically debride, remove all the dead necrotic tissue, including the dead necrotic bone also, and then put a VAC dressing. VAC dressing, you all know about the VAC dressing. There is a regular VAC dressing which gives the negative -125 pressure to this. Then ultra VAC where you can irrigate the wound with the help of the solutions. The machine can stop, say you can set it at 4 hours or 5 years. You can how much amount of fluid you want to send into the wound, and how much soaking time is there. Again, the machine start to absorb it. So that way you can irrigate the wound. It gives a better graduation tissue than the normal VAC. Once the wound is cleaned, you can go for a skin grafting and save the foot. This patient is gentleman is still walking on his foot. Again, here I will like to stress the importance of regional blocks. Even this patient was having the 20% ejection factor, and in normal cases, this anesthetist might have said it is not anesthesia. But in a regional block like sciatic femoral block, popliteal block, or ankle block, we can do many surgeries, almost all the surgeries of diabetic foot into this regional block in any diabetic patient, because most of the diabetic patients are elderly patients having kidney problems, having arterial disease, So many problems are there. So still you can manage this patient with the regional block. Coming to the IP joint ulcer, the cause for IP joint ulcer is a stiff MTP joint. And the treatment is Keller's arthroplasty to give the permanent relief. In the Keller's arthroplasty, what you can do is open the joint, MTP joint, then cut the proximal 1/3 of the proximal phalanx and make the joint loose. Once the joint is flexible, the ulcer heals within no time. The gentleman has come 4 years back to me and still there is no recurrence. So this can be like this. There are so many preventive and curative surgeries in diabetic foot. Not only the amputations are there, but there are a lot of surgeries are there, tendon balancing surgeries are there, which can be offered to the patient, provided the patients come early and have a good blood supply. So if the patient doesn't come, this patient was offered the Keller's arthroplasty, but he did not go for that. Ultimately, you can see there is an infection of the ulcer. Infection, I tried to save his toe, but there was FHL was infected, and finally he landed it into the grade 2 amputation. Once the grade 2 amputation is there, the second toe goes for the flexor deformity, and again he can develop into a ulcer at the tip of the toe. Later on, he can again land up into a problem. So if the patient present early and have the good blood supply, ask them to go to the surgeon who are doing the Keller's arthroplastics. Infections spreading along the FHL tendon. This patient has a gangrene of the toe, and you can see that it was a spreading infection. So instead of opening the foot completely, you can open the foot into the midfoot level and open the tendon, remove the tendon from the infected region, so that without cutting through the tissues and spreading the infection, you can remove the infected FHL tendon from the infected region, and then the patient has gone for the amputation of the toe and healed well and now still walking. Sometimes the patient present with a badly infected foot, and there is a infection of the FHL infection spreading along the FHL into the tarsal tunnel. And so now here what we have done is open the FHL into the just above ankle region and removed it from the infected region, so that the spread of infection is prevented without opening of the much of the foot. So these are generally, you must know that the infection in the diabetic foot spreads from the distal to the proximal level, because all the tendons and muscles are placed vertically, except one tendon. All the tendons are placed vertically, so they go along from the distal to the proximal region, and you can say these tendons are the highways or superways of the spreading of the infection. So removing of the infection along the tendons can save the foot and give the normal looking foot to the patient. This patient has gone afterwards into the angioplasty, and later on the foot we give the WAC dressing and wound heal completely, and he is still walking. This lady had a callus for 8 months. So if the callus is not removed, what happens? You can see in this case, there was a swelling of the foot 5 days, and within 2 days, this spread to the dorsal region of the aspect of the foot. You can see the cellulitis spreading in the dorsal region aspect of the foot. And when the patient presented on the table, there were already blister formations suggesting the necrotizing fasciitis. Blood count was, WBC count was 30,000, culture or MRSA. So we treated this patient with the levonormal hexafilin, so MROC, recently available in India. So within no time, in 3 to 4 days, the count has come down to the 10,000. Of course, even after the debridement, you can see the tibialis anterior is totally infected, sloughed out, and the cause was a osteomyelitis of the base of the first metatarsal involving the cuneiform bone. So we have to resect this base of the metatarsal and cuneiform bone, remove the tibialis anterior tendon. There was a pus into the anterior compartment of the foot. We have to remove that. Then after debridement, skin grafting, and you can give back the foot to the patient. This patient from Alibag having a long-standing diabetes presented with a wet gangrene. So what we did is the debridement, amputation of the infected toes, and then followed by the skin grafting. So deformed but a good walkable foot is given to the patient, and that should be the aim of every doctor or a surgeon. Even though the foot is deformed, he can walk on that foot and prevent the complications later on with not having the foot. Coming to the osteomyelitis of the proximal, you can see that there is a proximal base of the distal phalanx was involved. So it was resected and the posterior flap was taken and it was sutured on the wound, and you can get a well-healed foot and a great toe with a small great toe projection, satisfying the patient that he has a great toe. This is osteomyelitis of the MTP joint. This 56 years old lady with a bank worker coming to me after 3 unsuccessful attempts by the orthosurgeon of debridement locally. It requires the radical resection, as I told you. They have to resect the bone at the healthy margin, then only the ulcer will heal. Otherwise, you do repeated debridement and keeping that small ulcer over there, it will not going to heal and it can spread. So what we did the resection of the infected bone, and within no time the ulcer healed, and now it is more than 4 years she has a healed ulcer and no problem with that. Sometimes there is a heel ulcer infected. We did the debridement and we put the antibiotic beads into that. As we all know, the diabetic foot, there is a vascular compromise is there. The antibiotic doesn't go into the higher concentration into the infected area. So what we do is we use the antibiotic beads. These antibiotic beads are made up of a calcium sulfate hemihydrate. We soak them into the culture specific antibiotics and then dry it and then put that into the wound. And then close the wound. This antibiotic is released there for at least 3 months. So gradually there is a release of the antibiotics curing the infection. Even though if you are resected the bone and if you put behind a small amount of infected, that will be taken care by this antibiotic bead. So it helps into healing of the ulcer. Another patient of heel ulcer, we did the partial calculectomy and used the Dermacell advanced wound matrix that I will talk to you on later on. And once the complete partial calculation, the Dermacell was put, you can see the convex structure, the formation of the bone is there, and the patient is healed within no time. And after 2 years also, there is a healed ulcer. As I told you, this necrotizing fasciitis is a rare serious infection which spread rapidly along the soft tissues and it can involve into the muscle and also. So if you are not treated early, they can land up into the amputation or even there can be serious life-threatening infection also. So requires is a antibiotic, good debridement. You can see the infected fascia spreading along all over the foot. So we did the good debridement and then back dressing, skin grafting, and saved the patient. Another patient come to with a small ulcer near the knee, but the infection spread rapidly. We had to open the complete leg, remove the infection completely, then put a back dressing, and then skin grafting, and then the patient now is going to his office for last 6 to 7 months without any problem. Now coming to the angioplasties, you can see there is a gangrene of the toe and there must be investigated. Any patient coming with a vascular compromise, you must investigate there and there in your clinic with the handheld Doppler. There is a one monophasic, biphasic or triphasic flow is there where this is the pulsation palpable or not, you must see that, investigate. You can see there is a triple artery disease, below the artery disease. So we could establish flow into the one artery. Straight line artery flow is the aim of the interventional radiologist. So once the flow is established, in no time, and then you can give the normal looking foot to the patient. This small looking gangrene of the toe. He's a 34 years male with a chronic smoker. Smoking is a very bad in the diabetic patients. So anytime you could have gone for the just removal of this. It is a small problem, but when the Doppler, when we could see that there was a pulsations were not palpable, we can see there is a patient was subjected to the angiography. There was you can see there is a calcification of superficial femoral. Yeah.
Excuse me. How much time will take for further?
Yeah, just for 2 minutes more. Yeah.
Okay, sir. Thank you.
So in this peripheral this thing femoral poplate bypass was done and patient wound heal in no time. So there are then again the advanced food matrix are there, which are cell containing matrices and cell free matrices are there available. Cell containing matrix not available in India. We can have a cell free matrices like Integra, Dermacell, Metridium, etc. So this is in the patient whereas localized necrotizing gangrene, we put a Integra, then debridement, skin grafting, and this thing. This is another patient having undergone amputation of the right foot 2 years back after angioplasty. This patient has come to me with this ulcer with no pedal pulsation palpable and having the condition that you should not go for an angioplasty and heal the wound. So we tried so many things. Debridement, no, this thing was there. We tried then again the surgical application and any other these things. We tried Veraflow therapies and then ultimately use the Dermacell. And after 5.5 months of first debridement, the patient healed well without a problem. And this is after the 1.5 years after walking this patient on the one with the prosthetic limb on one side and the special diabetic footwear on another side. This is the patient who is walking. Thank you so much.
Thank you, sir.
Thank you.
Any question from audience?
Yeah.
Yes, sir.
Which antibiotic you use for that?
Any questions? You can ask me.
Okay, one question is from audience, sir. Which antibiotic to be used in diabetic food?
Which antibiotic? Generally, as I told you, when the patient comes to you earlier, you must go for a culture sensitivity, and depending upon the culture sensitivity, you can use the antibiotics. If the patient, there is a localized infection, you can start with the oral antibiotics, and if there's spreading infection, can go for IV antibiotics, higher antibiotics. Then there should be a combination of the antibiotics which can involve the gram positive, gram negative bacteria and anaerobes also. So depending upon that, you can use the various antibiotics.
Thank you, sir. Dr. Shahade, sir, can you answer this question, please?
I could not get the question.
Okay, we'll take the questions afterwards, sir. Okay. Dr. Nagate has to leave, so may I request Dr. Meenakshi Deshpande, madam, to come onto the stage and to felicitate Dr. Nagate, please. I request Dr. Shahade sir and Dr. Patil sir to join for the felicitation.
Beautiful lady talking here. What else you want?
I request Dr. Vinaya madam, please stay. Vinaya madam to come onto the stage, please.
Because they want to leave early, so
Dr. Kothur, sir, may I request you to be on the dais? He would be the next faculty.
I invite everybody on the dais.
I request everyone
All
to
the
come on the
chairpersons and managing committee members on the dais.
Please come on the dais. Paryani, sir.
We have a group photo because two faculties are leaving.
He wants to.
Sir, yeah.
एक ऊपर में क्या ऊपर
Yes. Thank you.
And now we proceed to Dr. Kothur's.
Yes.
Hello. Dr. Vivakar Vacharajani, sir,
yeah,
are
I
you
am
ready
here.
with the lecture?
Yeah, I am here. I am ready. Hello, am I audible?
Yes, sir.
Hello, am I audible?
Sir, we can't hear you, sir.
Hello, hello, am I audible?
Hello, good afternoon, sir.
Hello, am I audible now?
Yes, sir.
Hello. Hello.
Yes, sir. We can.
Am I audible?
Yes, sir.
Okay, okay, okay.
Yeah, I'll introduce you, sir.
Hello.
Dr. Vivakar Vacharajani is a best general surgeon in Rajkot at Temple of Food. It is his hospital's name. It is at Yagnik Road, Rajkot, and first of its kind. And he's practicing since last 25 years. He's got a book on safe food in diabetes. And another thing is he's taking diabetic care with food care and surgery and health education, psychotherapy and rehabilitation of diabetes patient. So over to Dr. Vivakar Vacharajani, and he'll be talking on offloading. So over to you, sir.
Hello, thank you. I'll just share the screen.
Yes, sir.
Hello.
Yes, sir.
Yeah. So good afternoon, everybody. Am I audible now?
Yes, sir.
Slides are visible.
No, slides are not visible, sir.
I have shared this screen. Is it not visible to you?
No, sir.
Just let me check. I have already shared the screen. I already shared my screen.
We can't see your slides.
Just a minute.
Yes.
That?
Yes, sir. Yes, sir.
Now can you?
Yes, sir.
Okay, fine. Yeah. So offloading and footwears in diabetic foot is, I think, today's subject. I thank the organizers and IMA Pune to invite me to share my views. Let me tell you, friends, hand and foot surgeon Dr. Paul Brand once said, diabetic patients had congratulated me on my footwears rather than the prescription and the surgery which I did. So this is what is the importance of the offloading and footwears. Foot ulcers in diabetes are more or less like pressure sores and bed sores. Offloading of unperceived areas of plantar stress is one of the several critical weapons in preventing and treating diabetic foot disease. And the main important reason is insensitivity, the neuropathy, which is creating the problem. And this neuropathy is the root cause why we need to think of offloading. Otherwise, patients without neuropathy, patients without diabetes, they can feel pain and discomfort in certain areas of the foot and they can protect their foot. But diabetic patients cannot. And the footwears reduce the shock and it reduces the locomotion and motion of certain areas of the joint, which creates a problem in diabetes. Now, how to select a patient for diabetic footwear and offloading? See, healed ulcer patients, 28% have recurrence at 12 months and 100% have recurrence at 14 months. So this is what is the statistics. And here is the role of offloading and advising specialized footwear. To my opinion, all newly diagnosed patients should be advised footwears, not to wear slippers and not to wear chappals. All patients at risk, patients with ulcer, TCC is the first treatment, then footwear. Half shoes to be advised to certain patients, and one partially amputated foot and other normal foot patient also needs the footwears and offloading advice. But many of the patients need mixture of modifications, not only one. Offloading footwears provide room for accommodating deformities, provides adequate depth for accommodating insoles, pads, and socks, reduces loads at critical areas, transfers load. It also can help in modifying the gait. But mind well, again and again I'll tell that offloading devices and footwears are better advised for healed feet and deformed feet, but not for ulcer healing. Now, $1 million question, how to decide where to offload? See, I'll not go in the details because in 20 minutes we cannot discuss more, but clinical examination many a times gives us the clue which is the area which is the area high risk or where there is callosity or the area where there are chances of ulceration. Footwear examination of the patient also can give us an idea where really we need to offload. There are methods like plaster cast, wax and sand, foam box, kinetograph, barograph, Harris bead mesh, pedotrack, optical pedobarogram, image system, foot scan. All these are the devices which are available. And now there are varieties of foot scans available, and there are computer assisted devices and computer assisted manufacturing of footwears for offloading. This is just an example, a best and simple device which is since so many years, Harris bead mesh. We'll not go in the details of other devices. Now friends, let me tell you, customized insoles, they do majority of the work to do offloading. Custom made molding high quality foot impression foam and taking plaster cast can give us an idea of how to make a offloading customized insole. Now, there are foot ulcers in different areas which requires different types of offloading, like 4-foot offloading. The 4-foot wedge type of a footwear can be used, and for patients with good dorsiflexion range of motion, good for ulcers under hallux and lesser digits. This is the 4-foot areas of plantar pressure release. Rocker bottom shoes with inner soft offloading insole also is useful for 4-foot offloading. Again, specialized footwears with inner soft offloading insole and outer hard rocker bottom sole is useful for offloading the midfoot part of ulcers or midfoot callosities and midfoot ulcerations. For heel, we have heel wedge postoperative shoes only for patients with stable ankle. Now, very important thing is, for unstable ankle, these types of footwears cannot work. So, stable ankle with heel ulcers or heel at risk. These are the types of footwears that can be prepared. Now, very important thing is, there are so many patients who are operated, toe amputation is done, and because of toe amputation, there is deformities of the foot. There are created prominences of metatarsal heads, and for this, we advise them either fillers and then specialized footwears. Customized orthotic insole with filler with proper footwear is best option to prevent any further deformities of the toes and subsequent callosities and ulcerations. Rocker sole, I already said. Now, there are simple devices available like silicone devices for pressure relief. An example is a silicone ring, or there are silicone hallux valgus splints available, which is very useful in preventing the pressure areas and preventing callosities and ulcerations. Now, we have seen so many patients with hammer toes and mallet toes and claw toes. All these patients need offloading and silicone toe splint to relieve pressure from toe tip. There are multiple toe rings available, single toe rings available, which can provide offloading in the tip of the toes and preventing callosities, etc. Now, there are complicated charcot feet and very unstable feet and ankle, which requires different types of cast walkers. Removable cast walkers are good for patients who are good compliant, very well compliant patients. They are cost effective as wound can be inspected without need for new device. Pressure reduction is excellent, but it can be difficult for patients with ambulation problems. Requires skilled persons to provide this and may require height accommodation for contralateral shoe. See, if it is one limb device, then the other limb requires height adjustment. See, I said that charcot foot, for general physicians, it is very important how to diagnose charcot foot, what to do for charcot foot, which is very essential because this is the foot which, if diagnosed in early stage and provided education and provided specialized footwears, then the midfoot disruption can be prevented and patient's limb can be saved. There are pneumatic walker diabetic system type of devices available where really there is air bed for the foot and ankle, and it gives excellent results over a long time. For patients with unstable ankle, we have customized ankle foot orthosis with rocker bottom outer sole for a patient with charcot and ankle instability with proper offloading inner soft plastazoid or evazoid lining type of insoles. Crow is one device for specially meant for charcot foot, but total contact cast is always better than these types of devices, but Crow is an excellent device for charcot foot. It's a shoeless design with rocker bottom. It helps to distribute the weight bearing forces over the entire lower limb and minimizes the peak pressure on the plantar surface. It looks like the ankle and reduces, it locks the ankle and reduces forces again acting on the ankle. Let me tell you, friends, in our Indian weather, the TCC, total contact cast, is many a times very difficult to apply. The moist environment, the patients working in farm and laborers, they cannot maintain the total contact cast. Otherwise, this is the gold standard offloading application. And there are different devices for partial foot amputated patients, and partial foot amputation with unstable ankle again needs a specialized orthosis, because if the patient wears only footwears, the ankle cannot be made stable and it creates a problem. See, I have already said some of the aspect of the outsole modifications. We have forefoot wedge, we have heel wedge, we have rigid carbon plate in the outsoles, we have rocker and roller outsoles. But mind well, the thing is, what we have observed is, if the heel height is more than 2 inches, there is a major shift of the whole weight of the body to the forefoot. So a special advice to diabetic patients not to wear a high heel type of a footwear. So these are the devices and outsole modifications available. Friends, offloading, one part is mechanical with the help of footwears and orthotics. The other part, very important, is offloading with surgical methods. Today only, I was attending one webinar on surgical methods of offloading and plastic surgical methods of offloading. So there are different surgical procedures which can be done. Achilles tendon lengthening is one procedure. There are silicone injections under the callus, then callus debridements to be done regularly. Metatarsal head resection is another procedure which can restrict the pressure. Osteotomies of different metatarsal bones, osteotomies of midfoot collapsed Charcot foot, and there are Keller's arthroplasties. See, there are so many number of tendon transplantations which are done, tendon transfers which are done, that can aid to offloading of the pressure bearing areas. And of course, we need to do correction of deformities. So friends, let me conclude with the basic conclusion remarks. Patient of plantar ulcer is not supposed to walk unprotected. This is one very much important principle in managing a diabetic foot patient. For healing of an ulcer, footwears are not ideal. It is always TCC, TCC and TCC, and rest of course. Total contact cast is the gold standard treatment otherwise to prevent recurrences of ulcerations. Orthotic correction of deformities help to prevent foot problems. Stabilization of foot and ankle joints work as icing on cake for better healing. See, once the healing process is not there, it doesn't mean that dressings and medicines will work. Certain amount of immobilization is also required for midfoot ulcerations or ulcerations around the joints. So this is again very important. And compliance of wearing footwear is so less that every time we come across the non-compliant patients, recurrences of ulcerations and infection. Usually, patient wears comfortable footwears rather than scientific footwears. This is again a very difficult thing to explain. But I always tell my patients that medicines are always very painful, or injections are painful. Still, we go on taking. See, medicines are not sweet, but still we have to take. Similarly, for preventing the foot going for infection and recurrent problems, it is a specialized footwears. It may not be comfortable, but it should be useful. So friends, I think in short, offloading and footwears is one concept which is less understood, and so is the problem with recurrences of ulcerations and minor and major amputations. thank you very much. Again, I thank the organizers for inviting me to share my views.
Thank you very much, sir. And you are very much nicely explained about the offloading. And I think it's a real, people are not taking it into account. We are how to use special diabetic footwears. Yes,
Yeah.
We have observed that. So thank you very much, sir, again.
My pleasure. Again and again, I thank the organizers, and I'm sorry that I was not in contact with you continuously. Today, you had to remind me, but I was very busy with operative workshop, which was more interesting for me to do. So, so sorry again.
Yes, sir, it's okay. Sir, please answer your
Yeah,
screen.
I'll
Stop
sharing the
screen.
screen. Yeah.
Yes, sir.
Okay.
Yes, sir. Thank you, sir. Thank you. Now, the next lecture is on peripheral arterial disease. It is by Dr. Advait Kochurkar. I think he's from, everyone knows him. He's from BJ Medical. He has done MS from BJ Medical and DNB at KM Hospital, Pune. He is MRCS from Edinburgh. He has fellowship in vascular surgery at Nizam's Institute of Medical Sciences, Hyderabad. Then he has done the fellowship at Royal Victoria Hospital, Belfast, UK, and is working as a consultant at Dinana Sayadri, Pune Hospital, KM Hospital, and he's practicing at Sanjeevan Surgery at Gole Road, Pune since 2006. So, yes, sir, welcome here.
Okay. Thank you, madam, for your kind introduction. I would like to thank the organizers and Dr. Shahade for inviting me for this talk. So I know I'm keeping you from your lunch, so give me 10 minutes. I'll finish all this in 10 minutes. Yeah. So I'm just going to talk about vascular issues that come in diabetic feet, and it is from the vascular surgeon's perspective. So my basic problem that I see is that there are differences in the expectations and the reality that occurs when a patient is referred by a physician to a vascular surgeon. So what I'm trying to do in this talk is to try to bridge that gap between the expectations and reality, because sometimes physicians would not know what would happen. म्हणजे हा patient आपला पाठवला की कसा येईल परत नाही येणार, will he come back with an amputation, will he come back with both his feet? Nobody knows what is to happen. So I just want to give you an overview about what we do and how things happen. Okay, so one of the important things that I think is that in diabetic feet, physicians should need to understand that referrals need to be done. Diabetic foot is not a single person's perspective. I think it needs a multidisciplinary approach. And the more you talk to people, the more you get to look at the diabetic foot from their point of view and involve them in the management. It helps. So I think a referral does need to be done. It needs to be done to the right person. So you need to decide whether you're going to get a surgeon to do it, whether you're going to need a plastic surgeon. Do you need an interventional radiologist? Do you need a vascular surgeon? Now, just a point there is, from the vascular point of view, the advantage that as a vascular surgeon we have is that we have the option of going for an angioplasty. So we do a peripheral angioplasty on our own. And if things don't work out or there are complications, we can deal with them right away. So I think that makes a lot of sense. Plus, we have the surgeon's perspective on the diabetic foot. So we know what a surgeon in the future, by talking to a plastic surgeon or a surgeon who does diabetic feet, we can actually discuss the whole thing with them. Look, I'll be able to do this, and how can you take it up from there? And then you also need to refer the patient at the right time. Referring a patient too late is just a big problem because nobody can do anything. If you have a non-reconstructible vascular disease, there's not much anybody can do anything about. So I think that is what I would think of as an optimal referral, and then you keep correct expectations. So this is something that we normally at this stage would get a patient referred to. Now this becomes very difficult for us to manage. You know, you need to look at the angiogram, decide whether you can do it, whether you can get an inline flow. So what we are looking at is, there is a concept called as angiosome concept. So depending on where and which area that artery will supply the blood to, is the primary artery that we would want to open up. So like this, in this situation, you would want to open up the dorsalis pedis if possible. Otherwise, you will not get inline flow. So we know this over 50% of non-traumatic amputations are due to diabetic feet. We know that if you do an amputation on one side, you would end up with an amputation on the other side with a higher risk. And say 40% of our patients at the end of 5 years are not going to be there. So that is a big problem that we have. So we have to take this disease a bit seriously. So it is 30 times more prevalent in diabetics, calcification of the media. So what we actually get is a lot of calcification in the media of the artery, which tends to make these arteries, which are like lead pipe arteries. So you do not get pulsatile flow in this artery. And that is what causes a problem. Sometimes what you do is you can get a proximal angioplasty or a bypass done, and then the distal arteries are so rigid that they do not give you a pulsatile flow, which is not a very good sign, because eventually these arteries don't do, these patients don't do as well. So now this slide I'm just going to skip over, because that is the what is the differentiation between a neuropathic foot and an ischemic foot. Sorry. So when a patient is referred to us, what is the clinical scenario? What we tend to do is we tend to see if there are pulses or not. I think this is something that a lot of people will not do in clinical practice. So they just are too lazy to get up and feel the pulses. They will rather ask the patient to spend 3,000-4,000 rupees on an arterial Doppler rather than go and feel the pulses. A lot of times patients, when they are sent to our OPD, do have pulses which are palpable. And then at that point, I would say, don't refer to a vascular surgeon. Pulses are palpable. What you are going to require is to work on the micro scope or the micro level of the arteries rather than the macro level. So you would prefer to send this patient to a plastic surgeon if required. Yeah. So we do a vascular assessment. If the pulses are not palpable, we do a Doppler. That gives us a fair idea. So we need to do a few investigations in conjunction. You can't say that, one test is what is going to do everything. Say, let's think about an angiogram. Now, when you're doing an angiogram, if you ask for a CT angiogram, if there is a lot of calcification, you're not going to be able to make out what is the contrast and what is calcification. So at that time, things like a Doppler will help. If you know that a patient has a lot of calcification in the arteries, especially the below-knee arteries, you might not want to do a CT angiogram, but you would want to do a MR angio, which helps to a slightly better extent in calcification. So a Doppler also is an important part of our assessment. You do the ankle pressure index, toe pressure index, TCPO2, and what we see is the probability of healing increases as the pressure indices are high. Now, once we do this, we think about an angiogram. We want the patient to be optimized. So what we would want to do is we speak to the physician again and say, look, you need to control the sugars, you need to control the blood pressure, you need to control the lipid profile, you need to control smoking. All these factors which will lead to a poor outcome are things that need to be controlled. If it needs to be done quickly, you just go ahead and control the sugars and blood pressure as much as possible. But we need a patient optimized, because we are going to do procedures which may have a lot of potential complications, which we may need to treat by surgery. And in which case, if they have concomitant coronary artery disease or cerebrovascular disease, which has not been picked up, then like Dr. Boyer said, that you would end up with complications and the patient would attribute the complications to you. So we need to think about all these things. So now just about angiograms, a catheter angiogram, yes, always was considered a gold standard. But what we need to remember is you're putting a needle into the artery, you're taking that needle out, you're doing various procedures through that. So there is a 1 to 3% risk of complications, which can be fairly disastrous at times. So you get aneurysms, pseudoaneurysms, tearing of the artery, sometimes thrombosis of the artery. So it is an invasive investigation. So you need to decide whether that investigation is the right one for your patient. Also, you get renal excretion of dyes, and we have options like using non-ionic dyes, which we can do, and a good person who is doing the angiogram can do a diagnostic DSA in as less as 10 to 15 ml of contrast. So we do have a good option in this, but you have to remember that it is invasive. You can do a CT angiogram, is non-invasive, reasonable resolution, but you have problems with calcification, like I told you. And a CT angiogram will roughly give a patient about 150 ml contrast. Now that can sometimes lead to contrast-induced nephropathy. So you need to be careful about that. angiography is non-invasive, no renal problems. Of course, there is a theoretical risk of, it's not theoretical, it happens in 1% over 20 years, but nephrogenic systemic sclerosis, so that is there. The resolution is not as good, especially if you have a foot which is infected, you would get to see the arteries as well as the veins and deep veins. So there is a big network and you can't make out which is the artery in all this. But a good radiologist who can sit down with the angiogram and work with it will be able to give you a good picture. You also have an option of what is called as a CO2 angiogram. So CO2 is used as a contrast agent. So what it does is basically it displaces the blood, and then with the CO2 you can actually see whether there are any lesions or occlusions of the arteries. There are no problems with the CO2. We have used it for an angioplasty as well. So when your patient is compromised from the point of view of the kidney, you would use minimum amount of dye and CO2 to diagnose and then treat these lesions also. The biggest problem is, of course, it is very painful because CO2 displaces blood and the CO2 diffuses right down into the toes, and these patients are in a lot of pain. So you need an anesthetist when you're doing the CO2 angiogram. The other problem is it can go into the lungs. So you have to be very careful when you're how much CO2 you want to give. So what are the options for interventions or limb salvage? Either you have a conservative approach, which most of the times is not required because technically when you have a diabetic foot, it is from the vascular point of view, it is defined as critical limb threatening ischemia, where you have a 20% risk of limb loss. So we have to go ahead and do something. So either it's an endovascular approach or an open surgical approach. So this is a regular, or what is called as POBA or plain old balloon angioplasty. So that is how it is done. That is the same principle as it is followed in cardiology. And then what we have are stent grafts and covered stents. So that is something that is a little bit newer to some people. So what we have is a graft. You have a mesh. The wire mesh is covered by a fabric. It is on the inside and the outside. We use it largely for aneurysms. But in certain situations in diabetics, when the artery is heavily calcified, when you are worried about are you going to rupture the artery or are you going to embolize a lot of material downstream from the point of plasty, you would want to use a covered stent graft. So the newer advances are drug-eluting balloons and stents. The same thing that happens with cardiology, you have newer drug-eluting balloons. There has been a little bit of a step back for vascular because there was a trial which came out and said that when you use drug-eluting stents or balloons in the peripheral circulation, the mortality is higher. That was thing that came out and it has been under a lot of debate. It took a step back because all the companies that were getting their drug-eluting balloons have now gone back a step. The debate is, we think that it is because a higher risk population was being taken up for drug-eluting balloons rather than a normal risk population. And it may be because just that the population may be at a higher risk of mortality rather than the tacrolimus or sirolimus, which is in the drug-eluting balloons. But what it does is it reduces the rate of restenosis. And then you have atherectomy devices like the Silverhawk or Turbohawk. So you can actually, it's a rotor blade which moves inside this mesh which is there, and you have a directional atherectomy or you have a conventional atherectomy device, and you can actually take out the plaque to some extent with the atherectomy device. Now in India, the DCGI has not given us approval for atherectomy devices to be used in the peripheral circulation. So we still are compromised to using them in the coronary circulation where it has been approved, but it is there and it should hopefully in the next few years get some use in the peripheral circulation because it tends to be quite useful when you've got a large cauliflower-like atheroma sitting inside the artery. The next thing that has come up, which is not included on this, is you have what is called as the IVL. So you have a balloon which gives shockwave lithotripsy. It's like a shockwave lithotripsy. So you have that balloon itself which gives shockwaves and damages the and remodels the calcium. So if you've got a very calcified lesion, you can put this balloon in. The cost is high, it costs about 1.8 lakhs. But if you can get that in, it remodels the entire calcium, and then you can use your balloons and devices to go up. So in a high patient, you might want to use that. The other concept, which is quite an old concept, is a subintimal angioplasty. So you're not going through the lumen, you're going outside the lumen between the media, layers of the media, and re-entering back into the artery, which is most of the time. So if you go in with an angioplasty, idea for an angioplasty, a lot of times you would go subintimally. And as long as you re-enter back into the true lumen, you're good. Your results will be as good. Only thing is you need to put them onto a dual antiplatelet for about 3 months or so. So some examples, short arterial stenosis, this is angioplasty at the bifurcation of the aorta, and that's been stent angioplasty and stented. This is stenosis, and then you've got a balloon which has been opened up. You can see the waist, and then the stent being placed in, and then the balloon after the stent that opens up the aorta. And that's a femoral angioplasty. So I don't want to go into details, but just how it is done, and that's the result that we had after the angioplasty. Now, before this, now what I want to talk to you about is, see, there was a concept that angioplasties are extremely expensive. And there was a time, basically, angioplasties used to be expensive because of the material that we used. But we used to put in stents everywhere. Wherever you could see a lesion, you would put in stents. But this concept has changed. So we used to put in what is called as a full metal jacket. So right from the groin to the knee, you continuously put 2 or 3 stents in. And over the last 7-8 years, it's been shown to have an extremely poor result. The stents do not do as well. So today, what happens is most of these patients, especially infrainguinal, so from the femoral down, we would always think about doing a balloon and a stent only as bailout. So today, when we give a patient estimates for a peripheral angioplasty, we are only giving them estimates for the balloons that we require and a stent only as a bailout. So it has reduced the cost. And this is to the advantage of the Indian population because costs do come down. Now, retrograde access is just an interesting case. So we came in from above, from the femoral coming down to the popliteal. You see the lesion in the popliteal and then the anterior tibial runoff. And we try to get into the anterior tibial, try to open up a balloon. Maybe that lesion is holding it tight, not letting the balloon go through. But the balloon just would not cross beyond this level. So what we did was we punctured from below. Fortunately, the patient didn't have ulcer, just had rest pain. So we punctured from below, put a wire up from below, crossed the lesion from the retrograde thing, and then snared the wire and got the wire down and completed the angioplasty. So just an interesting case. So when we come to surgery, this is how we end up doing surgery. So on the left, you see a long lesion. So you see the femoral, and then on this side, what we see is just the posterior tibial faintly seen below the ankle. And then you do a surgical bypass like this. Now, and this is a plaque which is being taken out. So this is the kind of atheroma that you would see, and you take the plaque out. There's a temporary shunt which is placed in, and you take out that plaque, and then you get an intima like this, which is left behind, and then you close this with a patch or a bypass as you want to. So now I just want to talk about what happens with surgery and bypass. So this came out in 2011. Limb salvage was acceptable, yet early wound healing occurred only in 21% of patients. So what it tells me is only I am not going to be able to treat the patient. I'm going to require other people to help me to get that wound healed. So this is only a part of the entire spectrum. This is one part of it, and then you require other specialties to help you. Patency rates. Now, for a bypass, for a distal bypass, by a distal bypass, you mean when we cross the popliteal and go down into the tibial arteries. So for a distal bypass, you've got a 3-year patency rates of about 70%. So it's not great, but it is not very poor also. It is 70%, which is an acceptable thing. And limb salvage rate at 1 year is 90%, at 70% at 3 years. When you're considering endovascular, you've got a slightly lower patency rate. So you've got 50-70% patency rate at 24 months. That's at 2 years. Limb salvage is high. But the advantage of endovascular is that you can go back in. Today, when we don't put in stents, and if our artery blocks off, we can go back in and re-angioplasty that artery. So we can get that done as well. And at that time, if you require a stent, you can put it in, but you can go back in. There are people who angioplasty as many as 7 times and then think about a bypass. So it would be that you're trying to postpone the bypass as long as possible. Morbidity and mortality is lower in endovascular procedures. We can do it under local, like any cardiologist can. We can just do it under local. If the patient is very anxious, a little bit of sedation, we have a cardiac anesthetist on standby, but we still can do it completely under local. So prevention of arterial disease is lifestyle modification, feel the pulses and document. You monitor these regularly, because a lot of times what I see is that the pulses were there 6 months ago and now they are not there. But that should not happen. As soon as the pulses are lost, maybe we can think about doing something early. So the whole thing about diabetic foot is do it early, do it early. Keep antiplatelets and a statin and refer the patient early. So diabetes foot is a deadly disease whose incidence is increasing. Costs to treat are high and may be recurrent. Amputations are high and associated with large morbidity and mortality rates. Treatments are limited, but they are reasonably successful. And preventing ulcers over the foot is paramount. From the point of view of the vascular surgeon, I would say that if you had to take care of the diabetic foot, feel the pulses. I think feel the pulses is a sort of a campaign that we think of, that feel my pulses. As long as they are there, they are good. And I think it's a multidisciplinary approach. So all of us need to work together to treat the patient. Thank you.
Yes. I just wanted to know, because of this corona, pulse now it's a very handy device. So taking a pulse is very subjective. So can we just put pulse ox and know how perfusion is, how reliable it is?
I think what happens with the pulse ox is it is dependent on so many things, like the ambient temperature. If there is an AC, my hands are cold now, my pulse ox probably will be 70%. So I'm anxious, I'm stressed out, maybe I'm under the AC and my pulse ox is not going to show up. If you get a good waveform, that means it is okay. But if you don't get a waveform, that does not mean necessarily that it is wrong. So I think it is an adjunct.
Excellent talk.
Thank you.
What I like most at the first slide was showing the perspective from surgeon's point of view, and if there was a eye symbol, so that was most interesting.
मॅडम म्हणतो आमचं युट्रस दाखवलं नाही म्हणजे
Gynecologist.
These surgeons, diabetic foot surgeons have problems, send the patient to Kokukar. They come very peacefully and start taking treatment at home.
तसं नाही sir, we try our best in that situation because I think
you rescue us so many times.
That is how we are supposed to. That is how our specialty is.
Yes. Thank you, sir. Thank you for your lecture. So, join for lunch. Join for lunch. 1 minute. Before that, we have one more felicitation of our chairpersons, Dr. Sanjay Patil sir and Dr. Amrish Shade sir. I'll request Dr. Meenakshi Deshpande to come on the dais. So after this, there will be a lunch on second floor at Kelkar Hall. And at 2 o'clock again, we'll join here for valedictory function.
1 second. Post-lunch, we start the session at 2:10, and it's very interesting session because Dr. Atish Shade madam is going to discuss all the questions which were asked in yesterday's exam. So all those who appeared for the exam, for them it's a very interesting session regarding diabetes, all the case-based questions, and those who are not part of the diabetes course, for them also it's a very educative and informative session with Dr. Atish Shade madam. So we meet at 2:10 and we'll start the session post lunch at sharp at 2:10. Thank you.